Good morning, ladies. I am so happy, and we're all so happy that you're here today. A big round of applause. Empowering women. What do you think about this venue and everything that we put together so far? Yeah? Isn't it impressive? Listen, a big rah-rah to our marketing team that has done such an outstanding job. Well, again, thank you for coming. Let me introduce myself. I'm Teresa Martinez, and I am the Senior Physician Relations Specialist that works with women's services. And I am so honored and privileged to work alongside with the most amazing physician experts that will be presenting to you today. So we just have the best of the best, and it's for you. So please enjoy and benefit from everything. Without further ado, let's kick off our program. I'd like to invite Dr. Lara Wittin to the stage. Dr. Lara Wittin is a fellowship-trained physician with board certifications in pulmonary, critical, and sleep medicine. She provides a wide array of consultative, diagnostic, and therapeutic services for adult sleep-related disorders at Advent Health Tampa. She is passionate about the benefits of sleep and advocates for this, not only locally, but at a national level in a leadership role at the American Academy of Sleep Medicine. Today she will speak about the important role has on women's health and some common sleep disorders and their symptoms to watch for. Without further ado, welcome Dr. Wittin.
Hello, everyone, and thank you for that very kind introduction. I'm talking about something I'm passionate about, and that is sleep. And I'm very, very honored to speak in front of women because sleep, especially, I'm not just limiting myself to obstructive sleep apnea today. Sleep is a foundational element of health globally. So I'm going to be talking about sleep in general. And unfortunately, our society just doesn't prioritize sleep as it should. But what I love is I'm talking to a group of women, and women are influential in your families, in your social circles, and at work. And if I can convince even one of you to prioritize sleep, that's going to have beautiful ripple effects into your families, into your friends, and into the broader society as a whole. In addition to talking about sleep as an important part of whole health, if I have time, I'm also going to try to talk about some pivotal things in women's lives that can affect sleep and learn about what sleep disorders women may be more susceptible to and maybe even protected from during periods of time in our lives. So without further ado, I'm going to talk about what sleep is. And, simply put, we are bombarded by stimuli all day coming into us that we're continually reacting to and working through. And so sleep is that one period of time of the day where we actually unplug from the environment altogether to focus our energies, our resources on renewing, restoring, and refreshing ourselves. That is very valuable time so that we are prepared for all of the challenges that are going to get thrown at us the very next day. So why do we sleep? This is not a comprehensive list. This is just the short list. But basically, sleep touches upon every biological function in our bodies. And so if we have something that's not going right with our sleep, it is like gasoline to any disorder or process that is smoldering and not working well in our bodies. So I'm going to come back to some of these elements later in the talk, so I'm not going to run through the list right now. But let's talk about how do we sleep. So sleep actually happens because two processes have to overlap themselves. And if they maximally overlap themselves, that's when we get our best and restorative sleep. So this is one of the reasons why we tell people to keep a consistent sleep schedule so that we can get these two things to overlap. One of them is the circadian rhythm. A circadian rhythm is any rhythm that holds to a 24-hour cycle. So how does a cycle know to stay within a 24-hour period? And it's largely due to our light exposure. So blue light has two really important effects on our body. So one is that when we get blue wavelength light hitting our eyes and affecting our brain, we actually produce a chemical called orexin, something that most of us probably have not heard a lot about. But that is the master switch in our brain that turns on all wake signals and consciousness. In addition, we also produce cortisol. And cortisol is a stress hormone. It helps us power through all of the challenges of the day. But it actually antagonizes. It's the antithesis of sleep. We cannot get into deep sleep if we have cortisol in our system. And so cortisol actually starts to release 2 hours before we actually wake up from sleep. So if you've ever woken up in those 2 critical hours and then had trouble going back to sleep because I can't get back into a deep sleep, yeah, cortisol's around, you're not going to be able to get into deep sleep. So this is why we drive in the point that in those 2 hours prior to bedtime, avoid blue light. You're actually giving yourself a mixed signal. You're turning on all of the wake signals at a time when we actually want the opposite to occur. Because as ambient light starts to dim and starts to go into reddish and more orange hues at sunset, it actually again signals the brain through our eyes that to start releasing melatonin. Melatonin isn't released right at sleep. It's actually released again 2 hours before sleep. Melatonin starts in those 2 hours, starts shutting down the wake pathways and starts flipping up all of the sleep pathways. So it's not instantaneous. So that 2 hours prior to sleep is critical for avoiding that really strong blue light coming in, because again, you're giving your body very mixed signals about what should be happening during that time. The sleep homeostatic process is the second process that affects sleep. And basically, the longer we stay awake, the more active we are, the more we burn down energy in our bodies. We expend it. And what we're left with is a metabolite known as adenosine. That adenosine builds up in levels in the brain that basically tell the brain enough. Shut down, and it actually helps to deepen sleep. So the more active we are physically and mentally during the day, the more we build up this chemical and we actually can deepen sleep. Exercise helps to do that. Caffeine actually prevents adenosine from hitting the receptors that cause sleep. So that's why caffeine keeps us awake. But we really want that pressure to build up at the same time that light is coming down so that we have those two signals overlapping. And before I get into the stages of sleep, there are certain hormones that are only released during sleep. Growth hormone and prolactin are two of them. So growth hormone, if you've ever had a child that's like grown and you're like, oh my God, it looks like you've grown overnight, that's when growth is happening. That is when it's happening. It doesn't happen during day. It happens at night. In fact, neurogenesis, the production of more brain cells and connections, happen at night. And that's a prolactin effect. Usually prolactin is something we think about with mothers nursing their children. But men and women produce it. And it actually helps to control our estrogen release, our testosterone release in men, and also produce more neurons in the brain. So sleep is critical for the actual release of these two. So if we're getting a good circadian rhythm going, if we're getting good sleep homeostasis, we actually produce 4 stages of sleep. So the 4 stages of sleep, first, non-REM 1. So non-REM 1 is drowsiness. It doesn't last for very long, but it's the only stage of sleep where 50% of us still aren't unconscious. So 50% of us hit that first stage of sleep, our eyeballs roll back in our head, 2 sheets to the wind, head hits the pillow, we're gone. The other 50% of us are still plotting, what do we have to do tomorrow, and what do I have to do, and I have to take the kids, and you know. So the other 50% of us are not actually unconscious in the very first stage of sleep. By the second stage of sleep, N2, all of us, 100% of people, are unconscious. And it actually makes up the majority of sleep and is the glue for the other stages. N3, non-REM 3, is an important stage of sleep. This is deep sleep, not REM sleep. Deep sleep is N3, and it's actually where our brain basically goes inert and it repairs itself. So this is absolutely critical for restoring our brain and getting it ready for all of the thinking that we have to do the next day. REM sleep is another deep level of sleep, but it's not deep sleep. It's not slow wave sleep. Actually, the brain is very active, thinking of all sorts of nightmarish and fanciful things during that time. But our body's paralyzed, so we do not act on those dreams during that time. And why that's critical is that this is the time when the body actually is locked down. It's not doing anything, so it's restoring itself. So basically, N3 and REM are important for the refreshing of the brain and the body. You need both of them. They're critical. Now, sleep is not linear. It doesn't start at N1 and then go through REM and then you wake up. Sleep is like waves on an ocean. It goes deeper, 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 lighter. Deeper, 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 lighter. And so every hour to 2 hours, you are coming back into N1 sleep. And again, 50% of us are not actually unconscious during that time. So if our bed partner is you know you're going to wake up to that, and that's going to disrupt your sleep. So this isn't necessarily something critically wrong with your sleep. It's actually probably your bed partner that you have to be like, I just heard someone talk about some sleep medicine. You might want to go see her. So now, even though these sleep cycles through these 4 stages every 1 to 2 hours, the composition of the cycling is not the same from the beginning to the end. So I actually marked here in green the deep sleep, the slow wave sleep. And I marked in red where the REM sleep is occurring. You can see that the first half of the night is really dominated by that slow wave sleep, and the second half of the night is dominated by REM sleep. Why is this important? If there's nothing else that you remember, I really want you to remember this slide. Because all sleep is not just sleep. Sleep is complex. And things are turning off and turning on during this entire process. So if you truncate sleep, you're not getting the full benefits. So what is really important about that first half of the night when you're getting that slow wave sleep? So what's happening is your immune system is actually activating. So whatever tumor cell, whatever virus, bacteria is in your system, your body is going on attack mode and trying to get it at that moment. And so at the same time, you're putting on your pain pathways. You are putting on your inflammation pathways. You are putting on all of your growth and repair pathways. You are going after any site of trauma, anything that needs repair, needs refreshing, needs renewing. Your body resources are going to basically rejuvenate you. At the same time, and you might think, well, why would you want inflammation and pain to be turned on when you're trying to be in deep sleep? That doesn't necessarily seem like it jives. But actually, the brain is inert at this point. The brain is shut off at N3 sleep. It's actually downloading all of the information that you took in during the day. So if you have a big test, if you have something that you have to memorize, this is the critical period of time for locking in those memories. The other really important thing that's happening during this time is something called the lymphatic system. So your brain is encompassed with cerebral spinal fluid that acts as a shock absorber. But during deep sleep, N3 sleep, the pores in the surface of the brain actually open up and let that cerebral spinal fluid literally into the brain to flush out the brain. It flushes out the tangles, the plaques, and all the debris that builds up. Animal models show that this is absolutely critical for lessening the effect of dementia down the road, because you're actually getting rid of the amyloid plaques and things like that build up in the brain and can lead to dementia. So that first half of sleep is absolutely critical for those particular features. Now, if you get that critical period of sleep, but you wake up right after it, you're like, oh, I got my 3-4 hours, I don't need those last 2 hours. Yeah, you're gonna start the day, but you're gonna be more achy and inflamed and everything like like that, because the second half of the night is to shut all of that down, to get all of the resources turned off so that you can basically direct the energy and other things for the things we have to do during the day, not the inflammation, not the repair, not the growth, not all of that. So it's actually important for shutting those processes down. Also, again, when you're dreaming, you're actually doing emotional processing that helps basically to help with anxiety, PTSD, and other things like that. And because the body is actually inert, again, the body's kind of having its time to restore itself. But at the same time, this is where muscle memory takes place. So if you are an athlete, if you are a musician, if you are a dancer, this is where your muscle memory actually is going to get encoded. So if you have them, if you have little athletes or musicians and things like that in your family, you want to make sure that they get that second half of sleep. So adults need 6 to 8 hours of sleep. A lot of people get panicky. I don't get my 8 hours of sleep. It's fine. It's fine. Actually, we've been looking at this since the 1940s. And if you map out obesity, if you map out cancer, heart disease, mortality, there is a U-shaped curve where the risk of all of those things increase with less than 6 hours and more than 8 hours. The best benefits to health occur at 7 hours of routine sleep with that range of 6 to 8. Now, because growth hormone and prolactin, which helps with brain development, occur during sleep, children who are needing to grow their brains, needing to grow their bodies, need a lot more sleep. So if you're caretakers of a child, whether you're a grandparent, a babysitter, or a parent, you need to be mindful that they need more sleep than we do. And so I've listed here on the chart what their needs are. Now, there's a few things about a women's life in general that can affect sleep. So let's talk about the first big thing, which is when we go through our menses and adolescence and periods. So when at that point, we start producing estrogen and progesterone. Good news, progesterone deepens sleep. Woo, woo, woo. So it actually gives us more N3 sleep in that first half of the night. It also helps to stabilize our airways. So we don't have, in our fertile years, we do not have as much obstructive sleep apnea risk as do our male counterparts. Now that's a double-edged sword because almost 10% of women can still have sleep apnea during their fertile years, but it's sometimes not recognized because our airway is a little bit more stabilized, so we don't get the heroic snoring that the men do. We just feel fatigued the next day and headachy, and we didn't feel like we got a good night of sleep, and that sometimes gets poo-pooed as other things. And so sometimes oh, I'm snoring and I'm shaking the house is not there. So sometimes practitioners don't recognize it. Women who have polycystic ovarian disease actually have an increased risk of obstructive sleep apnea during those younger years. What women really are at risk for after our menses start is restless legs. So when we lose blood, we lose iron. And iron is needed to make dopamine in the brain. Dopamine settles down movement. And dopamine is on a circadian rhythm, and it drops right before we go to sleep. So if we don't have enough iron, because we've lost it in our blood, and we don't have enough dopamine, and our dopamine levels drop, our legs become really, really restless, and that can interfere with our sleep. So moving on to pregnancy. Pregnancy is even worse for sleep. So especially in the second and third trimesters. So when that gravid uterus starts to grow, it starts to push on the bladder and has to make you run to the bathroom all the time. It creates more heartburn. It can cause contractions at night. More iron is being directed to the baby. So you actually have an even further increased risk of having restless legs and hard time settling down the body. And all of this leads to 30 minutes of less sleep in our third trimester pregnant women. And unfortunately, and they know it, like 46% will say, I'm having poor sleep. Unfortunately, poor sleep quality and short sleep are independently associated with an increased risk of gestational diabetes. Short sleep is also associated with increased risk of high blood pressure during pregnancy and a longer labor, something none of us want. So it's really important that we help to support women, especially in that third trimester, get more sleep, get good positioning, and even build in a little extra sleep time so that they can make up for the challenges that they're having. The worst time in the woman's life for sleep is menopause. So after menopause, 31 to 42% of people, or women, will complain of chronic sleep issues. Now, you might think back to, okay, well, that's probably because we're losing progesterone, right? Well, yes, you lose progesterone, that deepens sleep, but actually the counterpart, the follicular stimulating hormone that goes up, actually does the same thing. So sleep by itself is not really changing. However, there's two things that do go on. One is the vasomotor symptoms, the hot flashes. The intensity of hot flashes, especially if they're happening in the first half of the night when that deep sleep is supposed to be occurring, do horrible things to sleep architecture and fragment sleep. And so we actually have to treat those vasomotor symptoms. The other thing that happens is that with the loss of progesterone, our airways become more vulnerable. So women, actually 60% of women after they hit menopause will have obstructive sleep apnea. And they don't necessarily recognize like why all of a sudden am I snoring or not having as good a sleep. You were protected there for a while, but that protection goes away and we start catching up with our male counterparts pretty quickly. So to summarize, sleep affects every vital system. I've only touched upon a few things, but it underpins blood pressure control, the things that you crave to eat during the day, all of those things are influenced by sleep. Sleep is that hidden gem when it's going well, and it is that hidden beast when it's not going well, that affects health. So it is essential to growth, repair, immunity, metabolism, energy expenditure, learning, attention, and our moods. So please, please, please prioritize it. Follow good hygiene and address any underlying sleep disorders that you think you have. Address other medical and other factors that you think might be affecting your sleep, even if it's your bed partner. Get them in. And so I'm sorry that I don't have a lot of time for questions. I have 23 seconds remaining, but sleep is so important, and I wanted to give you all of that information, and I hope you found even one tidbit that's useful. So take care and enjoy your day.
Thank you. Thank you so much, Dr. Wittin. Next, I'd like to introduce Dr. Myrna Armenius. Dr. Armenius is a cardiologist and cardio-oncologist with board certifications in internal medicine, adult echocardiography, and nuclear cardiology. Dr. Armenius provides comprehensive cardiovascular care at Advent Health Tampa, including non-pharmacological and pharmacological stress testing, cardiac imaging, preventative care, cardiac care, and risk factor identification. Welcome, Dr. Armenius.
Hi, everybody. My name is Myrna Armenius. I am a cardiologist. I do specialize in cardio-oncology, and what that means is I treat patients who have cancer or who have heart disease and who are diagnosed with cancer, and then the side effects that are related to chemotherapy and radiation. And so I'm going to give just a brief talk on heart disease and some of the side effects of cancer therapies. Heart disease, like we know, is now the #1 killer of both men and women in the US. Coronary arteries are the little arteries that feed your heart. They carry oxygen blood to the heart, and this is when plaque builds up on the inner walls of those small arteries. That's what a heart attack is. Plaque is made up of fat, cholesterol, calcification, waste products from cells, and a clotting agent called fibrin. So hardened plaque is what narrows the arteries and reduces the blood to the heart. This can cause what we call angina, chest pain. The most common cause of a heart attack is when one of these plaques ruptures, and then a blood clot forms on the surface of that, and this completely blocks off the blood flow to that artery. Risk factors. So Risk factors of heart disease: age over the age of 55, family history of early heart disease, and this means a first-degree male relative less than the age of 50 or a female less than 60. Hypertension, high cholesterol, this is high LDL specifically, or low HDL. Diabetes, metabolic syndrome. What this means is central obesity, elevated triglycerides, high blood pressure, glucose intolerance, and low HDL. Kidney disease, smoking. Postmenopausal states increase the risk of heart disease. Psychological stress, depression, PTSD, inflammatory and rheumatic diseases, pregnancy-related complications such as eclampsia, preeclampsia, gestational hypertension, and diabetes later on in life can cause increased risks. Risks that are specifically unique to women. So early menarche, this is when you first had your period. Younger than the age of 13 is associated with increased risk of cardiovascular disease. Menopause, that is early, so less than the age of 44. Unfortunately, hormone therapy is not necessarily protective against this. Hysterectomy has also been associated with increased risk of cardiovascular disease. Premenstrual syndrome, so PMS, has also been linked to hypertension specifically. Birth control pills has been linked to heart attacks, strokes, and clots, especially in those in the age of greater than 35 who smoke, or greater than 39 or are obese. PCOS. And again, pregnancy complications. So later on in life, you can experience this if you had these issues during pregnancy. Hypertension, diabetes during pregnancy increases your risk for cardiovascular disease and hypertension by 2 times. Miscarriages, this does not include abortion, has also been shown to have a higher risk of heart attacks later on in life. The more, the higher the risk. Preterm birth, also delivery before 37 weeks, has also had an increased risk. Heart disease and happiness. So stress is related to heart disease. There is a link between the two, between also depressions and low levels of overall well-being. Depression is associated with more frequent angina, so more frequent chest pain episodes, physical limitations, lower perceived quality of life. High levels of depression are also associated with increase in mortality from heart disease. Now, cancer in the heart, how are the two related? In general, the same risk factors that you have of developing cardiovascular disease can also lead to certain cancers. But specifically, what I deal with is the therapies and the radiation treatments from different cancers that increase risk of heart disease later on in life. This is especially prominent in women's cancer, so such as breast cancer therapies. Patients with risks for heart disease are definitely at increased risk of having heart failure and disease if they do get chemotherapy and radiation. Side effects of different types of chemotherapies can manifest many years later. So we sometimes see, if anybody here has had a family member who themselves have been treated for breast cancer with what they call the red devil. The side effects of this can sometimes be seen 10 years later. The formula to prevent heart disease from this is the same as the general population. So there is some good news. If you achieve what we call life's simple 7, by midlife, you can help preserve cardiac function in late life and reduce your risk of developing heart failure, CAD, strokes, cognitive impairments, diabetes, CKD, cancer by over 50% in women and 69% in men. What are those simple 7? Stop smoking. Number 2, manage your blood pressure. And we'll go through each of these as long as time allows. 3, control your cholesterol. 4, reduce blood sugar. 5, get active. 6, eat better. 7, lose weight. So put very simply, right? This is a graph that was published in one of our popular American Heart Association journals. This just shows that if you have all these optimal risk factors before mid-age, in women, you have less than an 8% chance of developing heart disease. If you have greater than 2 of these major risk factors, then your risk goes all the way up to 50% of developing heart disease, and in men, greater than 69. So kind of sucks for men. Cancer in the heart. So patients at increased risk for developing heart disease include women, unfortunately. Patients greater than 60 years old, those receiving very high chemotherapy doses. So I do work with oncologists in terms of adjusting doses if they do start developing heart disease. Those with underlying heart disease already and getting cancer therapy, they need, that is my baby, shout out to my 18-month-old. they need aggressive risk factor modification. So I follow this Vanderbilt ABCDE approach to cardiotoxicity with my cancer patients in order to reduce their risk. And this is what you see up there: awareness, aspirin therapy if needed, blood pressure, cholesterol, cigarette smoking, diabetes, advanced diet choices, and exercise. And if you can see, this is pretty much the same as the Life Simple 7. So let's quickly go through that. Stop smoking. So there are 3 ways to quit smoking. One of the most effective is cold turkey. Method does not prolong this quitting process. It doesn't delay things, doesn't allow for excuses. And so this is one of the most effective ways. Reducing gradually, so help the patients reduce the number of cigarettes gradually. Smoking only part of a cigarette, so counting how much puffs you take from each cigarette, reduce the number each 2 to 3 days. Medications. Now, managing your blood pressure. Contrary to the past, blood pressure management has become a lot more strict. We no longer want blood pressures greater than 150 or 160 in older patients. Everybody should have a blood pressure less than 120 and a diastolic, the bottom number, less than 80. Elevated is already considered to be 120 to 129, the top number. And if the bottom number is above 80, you are already considered elevated. Stage 1 is 130 to 139. So we are getting much more strict, and 80 to 89. So there are different ways to manage blood pressure. I usually start with natural, and I'll go through a couple of those, and then pharmacological therapy. So ways to decrease your blood pressure naturally. Weight loss. This is Life's Simple 7, number 7. Heart-healthy diet. The DASH diet is the #1 recommended diet to reduce your blood pressure naturally. This focuses on sodium reduction, and if I have time, I'll show you that exact diet. Dietary potassium, so I have to be very careful with this. This does not mean supplementation if you don't need it, especially in patients who have kidney disease or medications that increase your potassium. But if we want, in general, for you to aim for about 3,500 to 5,000 milligrams per day. Increased physical activity. I'm going to keep coming back to this. And reduced alcohol. So ladies, no more than 1 drink a day. And 2 drinks a day in men. So we're not going to talk about that. Standard drink is about 12 ounces, okay, of a regular beer. Usually that's about 5% of alcohol. 5 ounces of wine, so 1 drink doesn't mean an entire bottle. Usually this is 12% of alcohol, and 1.5 ounces of distilled spirits. So that's about 40% alcohol. This is what we generally recommend. Okay, number 3 is control your cholesterol. Your bad cholesterol is the LDL. As cardiologists, we are obsessed with the LDL. This is what builds up in your arteries. If you are a non-diabetic, your goal is less than 90. No exceptions. If you are a diabetic, your goal is less than 70. So we get very strict. HDL is your good cholesterol. This is what carries the LDL away from your arteries and blood and back to the liver where it's broken down. Your goal is less than 60, and this can be increased by healthy fats in the diet, by fish, by nuts, and I'll give you some recommendations. Triglycerides. This is stored in the fat cells from your diet and used as energy source. This builds up with the LDL. Your goal is less than 150. And this is how we calculate your total cholesterol score, which the goal is less than 200. Reducing your blood sugar. So ideal fasting glucose is less than 100. Pre-diabetes is 100 to 125 or 140 to 199 non-fasting. This definitely increases your risk of developing diabetes and heart disease. Diabetes is considered greater than or equal to 126 fasting or greater than 200 non-fasting. Diabetes, as many of you know, is when your body doesn't make enough insulin or develops insulin resistance and can't make efficient use of the insulin it makes. This increases your risk of heart attacks. You should be tested for diabetes if you are overweight and over the age of 45, if you are overweight and under the age of 45 and have more additional risk factors such as high blood pressure, high cholesterol, family history of heart disease, African American, Asian American, Latino, Hispanic American, Native American, or Pacific Islander descent, or if you have a history of gestational diabetes or elevated glucose during pregnancy. Okay, exercise, everybody's favorite thing. So physical activity is anything that makes you move your body and burn calories. So the AHA, the American Heart Association, the recommendations are 30 minutes of moderate intensity aerobic exercise, at least 5 days a week, total of 2 hours and 30 minutes a week. Not too bad, right? 25 minutes of vigorous aerobic exercise at least 3 days a week or a combination, okay? For lowering blood pressure and cholesterol, 40 minutes of moderate to vigorous intensity aerobic activity 3 or 4 times a week. Now eat better, okay? So we want to aim to eat a diet that's rich in fruits, vegetables, whole grains, low-fat dairy products, skinless poultry and fish, nuts, etc. You want to limit your saturated and trans fats, sodium, red meat. You want to compare labels, select the leanest cuts available. The ideal diet meets greater than or equal to 4 of the 5 dietary recommendations, and I listed them there: fruits and vegetables, fish, fiber to carb ratio, sodium, and limiting your sugar-sweetened foods. Recommended diets. So the DASH diet, this is our diet that we recommend to lower blood pressure, okay? This is, and for overall health, but best in lowering blood pressure. And the next slide will give you the detail of that. This basically limits red meats, sweets, and sugary drinks. It's low in total fat, saturated fat, and cholesterol. High in fiber, potassium, calcium, magnesium, low in sodium. This is the actual diet. I won't go into it in detail, but if you want to take a picture, this is the best diet for blood pressure lowering. The Mediterranean diet is the other diet that the AHA recommends for weight loss. This is less effective on the blood pressure than the DASH diet, but it still does lower blood pressure. It doesn't prescribe a specific amount of food to each group, but this is the general idea between the two. This focuses on vegetables, fruits, nuts, whole grains, so pretty often, pretty similar idea. Meats and sweets are consumed less often. Okay. So bad fats are considered saturated and trans fats. Saturated fats are the animal products, so beef, lamb, pork, poultry with skin, butter, cream, cheese, other dairy products made from whole or 2% milk, and coconut, palm oil, tropical oils, cocoa butter. These are all very high in saturated fats. We recommend no more than 5 to 6% of total daily calories of this. Trans fats, this is what we create in industrial processes. This adds hydrogen to liquid vegetable oils to make it more solid, and if you think about it, it'll solidify in your arteries. It's found in fried foods, baked goods, so pastries, pizza, dough, donuts, pie crust, cookies. These are all called partially hydrogenated oils. This raises your LDL, the bad cholesterol, lowers your good cholesterol. So even packages that state 0 trans fat might still have some if the amount per serving is less than 0.5, because anything less than 0.5 is not required to be reported. So you might still have some in there, okay? On the your right side, these are some tips as to how to reduce this in your diet. Selecting lean cuts of meat with minimal visible fat, so round, chuck, sirloin, loin, trim visible fat, eat less. By choice or select grades rather than prime. Broil rather than pan fry the meat. Use a rack to drain off the meat when broiling, roasting, or baking. These are just some cooking tips, and you can skim through the rest. Okay, some more healthier fats. Monosaturated and polyunsaturated fats are the good fats. Fish, avocados, olives, walnuts, liquid vegetables such as soybean, corn, safflower, canola, olive, and sunflower. These are the good oils. Puree fruits and vegetables, you can use that in your cooking, so that can replace butters. Use these liquid vegetable oils instead of solid fats. So again, canola, corn, olive, peanut, safflower, soybean, sunflower, avocado, grapeseed, rice bran, and sesame. Real quick, because our next talk is going to focus a little bit more on this, but how to lose weight. Your BMI is the amount of body fat. This is calculated using your weight in relation to your height. The secret to losing weight is to burn more calories than you eat. In general, 1 pound is 3,500 calories. Okay? Women use about 1,200 to 1,500 kilocalories per day. Men use a little bit more than that. To lose weight and keep it off, you need to subtract about 500 calories per day from your diet to lose about 1 pound per week. This is the general equation. It can definitely vary for everyone. But the ACC recommends a deficit of about 500 to 750 each day. You need both regular exercise and a healthy diet to lose weight. You can't do this by diet alone, unfortunately. But a good plan includes this restricted calorie diet, nothing more severe, and 30 to 60 minutes of moderate intensity exercise. This is just a general helpful chart to show you how much calories you can burn by every single type of physical activity. So for a person who weighs 100 pounds, 150 or 200 pounds, bicycling for 100-pound for about at 6 miles per hour, you can lose about 160 calories. So this gives you a good idea of what type of physical activities and how much you can burn per activity. If you notice, walking, you can also burn quite a bit. So parking a little further from your office or your job, not looking for that first spot 100 times at the mall. Just go ahead and take that last row. It's all right. You'll burn about 300 calories. So the diets that we recommend, I get this question all the time as a cardiologist. We recommend comprehensive lifestyle changes in addition to calorie-restricted diets. These are usually the most effective diets. They're lower in fat, less than 30% of total calories from fat, or diets in greater total calories from fat, either from low carbohydrates or low glycemic load diets, or diets that target higher fat with average or low protein. These are usually the best diets. There are so many out there. I get a lot of questions about supplements as well. Supplements can be unsafe. A lot of them are not FDA approved or regulated. Some of them have herbal products that are not completely studied. And so there is a lot of research going to that. I get the question about Ozempic, the magic drug. And so it is FDA approved for patients with diabetes. We do not routinely prescribe it for weight loss, as well as Moderna right now. It is only approved for diabetics, but it does help with weight loss. Okay, this is where I got a lot of the diets and recipe advice and the lists of groceries and things that you can, a lot of my slides can be found in more simple terms from this website, heart.org. I give it to all my patients, as well as Life Simple 7. And so I definitely recommend going to this website and getting a lot of your information. And here are my references. Okay, I have less than a few seconds left, so if you guys have any questions, I'm happy to answer them after the talk.
Okay, thank you so much, Dr. Armenius. Next, I'd like to welcome to the stage Dr. Lisa Ferreira. Dr. Lisa Ferreira is an obesity medicine specialist at Advent Health, Tampa Bariatric and Metabolic Institute. She delivers a personalized weight management program to help you meet your healthy weight goals. As a board-certified obesity medicine specialist, along with her many years of experience as a family medicine physician, she's able to offer a well-rounded perspective with a focus on helping you not only improve weight, but improve other weight-related chronic medical diseases such as high blood pressure, diabetes, and joint pain. Dr. Ferreira is a double board certified in obesity medicine and family medicine. She's an active member of the Obesity Medical Society, the American Society of Metabolic and Bariatric Surgery, and the American Academy of Family Physicians. Today, she's here to answer some frequently asked questions about the unique weight management challenges women face. Welcome, Dr. Ferreira. So why is it so hard to lose weight and keep the weight off? Oh my God, the problem that we all have.
That is such a great question because it is super complicated, as we know. I always tell my patients there are so many factors involved. It's not just as simple as just go eat better and just move more and you'll be fine. We've told you that for years, and it's not true, really. Of course, there are lifestyle changes that certainly make a difference, and as we've heard beautifully, there are certainly things we can do. But this starts with genetics, this starts with family history, this starts with hormones. There are stress hormones. There are hormones involved when we are sleep deprived, Dr. Mateen told us. There are female hormones, of course, hunger hormones. It's so complicated. So there are a lot of factors in the background that are already working against you. And then we put our environment in that. Exactly. So we are sleep deprived, we are busy, we are running constantly, we are eating fast food because we're just on the go. Stress, there are just so many things involved in this. And then keeping the weight off, of course. Your body wants to regain the weight. Evolutionarily, if we think about thousands of years of humans, we weren't meant to lose weight. We were meant to keep it on. We didn't want to starve. And so the body knows as we're losing weight, the metabolism starts to slow down. There's this phenomenon called metabolic adaptation, where the body adapts and it doesn't want to lose weight. So your metabolism slows down. When you lose weight, your hunger hormones go up. So now you're hungrier. It's complicated.
It is. What is the best diet to lose weight?
That's tricky, right?
Tricky.
So we did hear beautifully about the benefits, and I think I can just go. I think that was fabulous. We heard beautifully about the benefits of eating styles, and we hate to say even diet, because that means that you go on to a diet, you're cured, then you go off the diet, and life is great. And it doesn't work that way. It's healthy eating styles. We do know the benefits of eating styles like DASH diet, Mediterranean diet. Really, it's just basics of nutrition. I talk to my patients all the time about, let's just start with fundamentals. Let's not call it a diet. Let's start with, are we drinking enough water? Are we not drinking our calories? Are we drinking a lot of Starbucks? Are we going to get our Frappuccino in the morning? Are we drinking juices, sodas, alcohol? Where are we getting our calories? And if we can really limit the calories we get in and limit those to 0-calorie things, and especially water, that's number one. Number two, we don't get enough protein, especially as women. We need to support our muscle mass. And so a lot of us are lacking protein. So if we think about just basic things we need to get, fruits and vegetables, less processed foods, eating more at home, just cooking. If you just cook at home as opposed to eating out. Meal planning, exactly. So just these kind of fundamentals of nutrition are very important.
Okay. Indeed they are. Is it better to do cardio exercise or lift weights?
Yeah,
Common question.
Yeah, I get that question a lot too, because our time is limited, so we want to do the best exercise. And really the answer is it's a combination. Of course, it's always about including both things. Because again, as we get older, we lose muscle mass. So we certainly need to incorporate that physical activity. But as we just heard, we do have guidelines on how much physical activity we should be trying to get. And we do say it is about 150 minutes a week of moderate intensity activity or 75 minutes of vigorous activity when we're looking at cardio. And so what that really means is that moderate activity would be like walking, or would be something where you could talk to someone but not necessarily sing. So it's getting a little breathless as you're moving. And then the vigorous activity is what we think about really sweating, jogging, biking, something really intense. But we also know, again, strength training. So adding in maybe 2 days a week, if you can, of some type of weightlifting, whether it's light weights, heavy weights, something, but remembering to build that muscle.
Very good. What does my weight have to do with cancer or other diseases?
Right. So we realize that cancer risk goes up when we gain weight, when we are struggling with weight. And we think that about 40% of our cancers are related to obesity. We know that after smoking, obesity is the next most preventable cause of cancer. So it is very important to think about our weight. We think about 13 different cancers are related to weight. 20% of deaths in women are related to cancers that are related to weight. So, and even there was a study done recently that showed that there's an 80% increase in cancer of early cancers. So they looked at data between, I think it was 1990 and or about 20 years worth of data, and found that there was an 80% increase in cancer, and the most quickest increase in cancer was actually breast, which is one of the most popular cancers in women, or the most common after skin, honestly. The highest incidence of cancer, of female cancer, is breast. So, and so breast, endometrial cancers, ovarian cancers, these are definitely related to weight.
Yeah. I know that when we go to the doctor, the last thing that we want to hear is, hey, you need to control your weight. But we really, us women, we have to take into consideration that, these are all the different factors of the why behind our docs.
And even
really
cancer recurrence. We find that once someone's been diagnosed with cancer, their risk of a cancer recurrence is higher if they're struggling with weight. So I see a lot of women who have already been diagnosed with cancer, and now we're looking to avoid that coming back. How can we do that? weight, improving weight can be a big factor.
Exactly.
Yeah.
Why does menopause seem to make it harder to lose weight? Menopause.
Right? We heard again about all the problems with menopause, and so we know that impacts our sleep,
Yes,
and
everything.
sleep is one of the things that impacts weight. Female hormone changes, hormones in general, just as we age, we know that we are more likely to gain weight. So we put all these factors together. When they look at data, though, they really think that it's not menopause that necessarily causes weight gain, but what menopause does is it changes where that weight goes.
Oh.
So when we notice as we're getting older and we're putting that weight on, you got it. So it's that visceral fat we talk about, all that stuff in the middle. So we're more likely to store it up in those places during menopause. And then we know we lose muscle mass as we get older. I'm again telling you all about the benefits of protein and strength training and keeping your muscles. And we know that muscles metabolize. We know that muscles protect our joints, protect our bones, but they also impact weight. So the less muscle mass you have, the more likely you are to gain weight. And again, as we age, we're more likely to lose that muscle. So it's all bad timing. It's all happening all around the same time.
Mm-hmm.
Yeah.
So we're hearing a lot about different medications and injections.
There's a lot in the news, that's right.
Can you talk a little bit about that?
Sure,
and
absolutely.
weight loss?
Yeah. So I always talk to my patients and I tell them that weight, number one, weight is complicated. Number two, weight is not your fault. It's not that you're just doing this to yourself. But also we have tools in the toolbox. We know we have a variety of tools that we use. And we know one of those tools, so we know nutrition, we know physical activity. Those are our two lifestyle changes. Absolutely important. We need to build on that foundation of those lifestyle changes. But we also know other tools we have in the toolbox. We know the importance of sleep and stress. So those are other things that I look into when I'm talking to my patients, especially women, with their sleep and stress. And then we look at medications, and we also look at bariatric surgery. So all of these tools are tools in the toolbox, and medications are a very valuable tool for a lot of people. One of my mentors talks about how weight is not, it's not your character, it is your chemistry. It's not willpower, it's hormones and so many other things happening. So medications can oftentimes be helpful. The other thing, though, is that when I talk to my patients, I look down the medication list of what they're already taking, because there are plenty of medications. We don't mean to do it, but we give you medications that cause weight gain. And then we yell at you about it and tell you, go lose weight, and then we give you more medication to make you gain weight. So you're welcome. And so we don't do it intentionally, but we do. So that's the first thing I like to do, is look down the list of medications and just make suggestions about what can we do to help you get off of medications. Not just add more, even if they're beneficial for weight, but just what can we do to get off some medicine. But there are also very valuable medications to help with weight loss, and these have been FDA approved. We did hear about Ozempic. That's the one everyone hears about in the news. At this point, Ozempic is approved for type 2 diabetes, but there is a version of it that is FDA approved for weight loss. That is called Wegovy. I don't know if I'm allowed to say brand names, but anyway. But there are a variety of other pills and other things too. And so it just depends on the person. It depends on their struggle. Some of these medications are helpful with the signals that cause fullness in the brain, so they can boost those fullness signals, like these injectable medications. There are a variety of them. There are antidepressant medications that are FDA approved for weight loss as well. So that can get to the eating behaviors that are happening. Stress eating, emotional eating, depression eating. We're all vulnerable to eating when we are anxious, these types of eating behaviors. So there are medications that can target that as well. And so I explain to my patients that medications aren't the only answer. I have patients who come in and say, I'll just take that injection. Just give me that injection and I'll see you in 6 months and I'm good. Yeah, it doesn't work that way. No. But putting all of our tools together are how people are most successful.
That's the importance.
Absolutely.
And how about once you start on these medications and you've lost your weight, do you gain that weight right back if that's the course of action that's taken?
Right. So we know that obesity is a chronic disease. In the past, we've never thought of it that way. We've thought, this is a lifestyle choice. This is laziness. This is willpower. And we now realize that that is not true. This is a chronic disease, and it should be thought of like other medical diseases. If you have high blood pressure or if you have a thyroid disease, and we give you medication and talk to you about lifestyle changes and put all the pieces together to control your thyroid, then would we pull your thyroid medicine away and tell you, okay, you're cured, go ahead, take care of your thyroid now? You can't change that thyroid hormone. You can't will that away, right? So we know that when we treat obesity in the same way, when we do use medications and our lifestyle changes and we put all of the pieces together and someone's successful, if we pull that away, they're likely to gain that weight back. We know that, again, the genetics, the hormones, all the pieces in the background, a lot of those pieces are still going to be there. Some of them are modifiable, sleeping better, stress reduction, lifestyle changes, and maybe medications won't be needed long term. And that's perfectly great too. That would be wonderful. But the reality is there's a lot going on behind the scenes that's not your fault. And so medications can be valuable for that.
I like that. Are there surgeries or procedures also? You did mention, right?
Yeah,
For weight
absolutely.
loss?
So other tools in the toolbox, and again that comprehensive approach that we do, that individualized approach that I do, where we take into account all of the different factors. We put all of the pieces together. One tool is not the only tool that we use, but for some people who would benefit from it, bariatric surgery is a very valuable tool. We know bariatric surgery is actually our most valuable tool we have in the toolbox. It's our most powerful tool. It's our most long-lasting tool.
Yes.
I have people who come in and say, well, I'm going to try this all on my own, and if I can't do it myself, if I'm a failure, then maybe I'll consider that as my last resort. And I always explain that's not the last resort. That's yet another part of the treatment plan. If we put all of our tools together at one time, then that's how we're most successful. So we have the conversation, is that the right tool? And if and when is it the right tool? But there are different options out there. We know the risks of bariatric surgery are so much lower than they used to be. We now say that we think that bariatric surgery risk is less than having your gallbladder out. No one thinks twice about their gallbladder, right? So bariatric surgery is very similar to that. Laparoscopically now, usually, just little cameras and holes, and you stay overnight. But it can be a very valuable tool. But again, we also know if we use that tool, we still want to make sure our other tools are in place. We still want to make sure that comprehensive approach is still happening.
That is the key factor.
Because
there.
it's not
a
just
comprehensive approach, and you follow these patients from start to, a continuum. Because this is a lifetime.
That's right. Because some people have bariatric surgery and then they regain the weight, and they say, well, now what? Now I really must be a failure. And again, it's not their fault. There's so many pieces, and they need support, and we need to continue using all of our tools.
Wonderful. And where do we go then to get this help? Obviously, you're one of our physicians and medical weight loss experts. So do we go to you, call?
Yeah, I would love to see everyone. I would absolutely love to see everyone. Time doesn't allow that, unfortunately. I wish it did. But the first place to start is with your providers, with your physicians. Talk to them. And we know from studies that providers are sometimes reluctant to bring up weight. Patients, people coming into the office like you are reluctant to bring up weight, partly because you've been told for years and years that this is just your fault. Push away from the table and go move more, and you should be fine. And so you're afraid to hear that again. Fortunately, these days, we are starting to really try to educate our providers as well that this is a chronic disease. This does need chronic management. This needs to be taken seriously, and that it's not your fault. It's all these complicated factors. So bringing up the question. If your provider's never brought it up, maybe they're wondering if they're going to hurt your feelings if they bring up weight, and so they're reluctant to do it. But saying, can we talk about this? I'd really like to know. What can I do? Insurances sometimes will cover dietitians, nutrition visits as well. It's always valuable. Physical therapy, if you have some ailments and pain. People say, well, I can't go exercise. They're just going to tell me go exercise, and I can't do that. What am I going to do? Physical therapy, or there are other things to try, but at least bringing up the question, start the conversation.
Yes.
And we should be starting the conversation as well, but we can all start the conversation.
Well, thank you so much, Dr.
Sure.
Ferreira, and I hope
Pleasure.
this segment has also helped each one of you tremendously. For the next presentation, I'd like to welcome Dr. Rachel Burke to the stage. Rachel Burke is a highly experienced board-certified radiologist with fellowship training in breast imaging at the K. Meyer Breast Center at Advent Health Tampa. She provides comprehensive diagnostic services and performs minimally invasive biopsies under all modalities, including ultrasound, mammography, and MRI. Dr. Burke is passionate about the patient experience and seeks to make everyone feel at ease through open communication. She works closely alongside the multidisciplinary team of physicians caring for our breast cancer patients and presents at the weekly tumor board. She's an active member of the American College of Radiology, Society of Breast Imaging, and the American Board of Radiology. Dr. Burke is a longtime Tampa native, raising 2 sons alongside her husband and their pet menagerie? Menagerie, okay. Didn't know. We're honored to have Dr. Burke here today to speak about breast cancer and knowing your risk. Welcome, Dr. Burke.
Okay, I think we're still morning, so good morning. So my talk's going to be a little different. I am a breast radiologist, so I am here to talk to you from my perspective, which is the person who finds breast cancers. But I actually am going to do a quiz. So this is going to be a little bit interactive. We're going to talk about breast cancer risks, screening, and treatment. So, okay. So, first question is a true and false question. I don't have a family history of breast cancer, so I really don't have a risk of getting breast cancer. I'm liking what I'm seeing. Okay, the answer is false. 3 out of 4 women diagnosed with breast cancer have no significant family history of breast cancer, and they are not considered high risk at all. The vast majority of breast cancers are considered spontaneous, and therefore every woman of a certain age needs to be screened. And I did not give you that age because that's the next question. At what age should a woman of average risk begin screening mammograms? Is it 40, 45, 50, or 55? Okay. It looks like the audience is going with 40, which is correct. The answer is 40. Yay! Okay, I'm proud of you. So 40 is the age at which most lives are saved. If we start screening at 40, these are the societies at the bottom of this slide, by the way. Society of Breast Imaging, ACR, NCCN, and the OBGYNs. We've all agreed that 40 is the age we should start. And the reason is that 1 in 6 breast cancers occur in women in their 40s. And actually, breast cancer can start earlier than 42. But screening the general population should start at 40 because that is the most lives saved. Which of the following factors contributes toward a woman's risk of developing breast cancer? Getting older, family history, breast density, or all of the above? You are all correct. All of the above. All of those things contribute toward developing breast cancer. And the 2 biggest risk factors are being female and getting older, which all of us in this room, if you're alive and being female, unfortunately, that is the truth, okay? So if you are alive and you are a female, those are the 2 biggest risk factors for getting breast cancer. Plain and simple. We cannot change that, which is why every woman must be screened. The other factors that I have on the screen, you can't change that either. Breast density, family history, Obviously, if your breast makes a prior high-risk lesion. So all of these things contribute. It's a multifactorial cause. Now, there are some things we can change, and we have alluded to those in other talks. What lifestyle change can a woman make to reduce her risk of getting breast cancer? Exercise and weight loss, you sound familiar. Limit alcohol and stop smoking. Diet rich in fruits and vegetables, or all of the above. I think you're noticing a trend in my questions, but that's okay. They're supposed to be easy. Okay, all of the above. Healthy living. There are some lifestyle changes, so although some of those factors we cannot fix, there are some things we can do to reduce our risk of getting breast cancer. And some of the talks before mine that nicely led into this, that we can reduce our risks. Now, at what age should you stop getting a mammogram? 65, 70, 75, or when you say so? Okay. So the answer is actually when you say so. There is no technical age of aging out of mammography, and do not let a physician tell you so, okay? I am here as a breast radiologist to tell you there is no actual age at which you should stop mammography. Women live well into their 80s and 90s, and breast cancers occur well into your 80s and 90s. And as long as you are in good health and want to know the answer to this question, you should get a mammogram. Plain and simple. If you live to your 80s, you have a 1 in 8 chance of getting breast cancer, okay? Just because you're not looking doesn't mean it's not going to grow. So you need to get a mammogram if you want to know the answer. You don't just say, because I suddenly turned 75, I'm no longer eligible. That's absolutely not true. Now, the other side of the coin is, if it's not going to change what you're going to do about it, if you do not want to know the result, if there's something going on in your life, it's not going to change the result, then don't come in. Because that's not going to help us. So, but there's not a magical number where we stop doing mammography. The reason is because if you just chart the age at which a woman is diagnosed with breast cancer and the number of breast cancer cases, that's this graph. And it looks like the beginning of the Iron Gwazi at Busch Gardens, okay? That's what it looks like. It looks like a slope like that. And it just takes off. At the beginning of 40 is really where it kind of takes off. I mean, a woman's risk of breast cancer doubles between 35 and 45. And so it happens before 40, it'll happen after 40, and it keeps going all the way up past 80. So these are just ages, number of cases of breast cancer. You will see, just keeps going. So we don't just stop randomly at a certain age. It doesn't work. So it's very important that you keep coming. Highest in women over 70. Median age of diagnosis is 61. Okay, how frequently should women come to get a mammogram if they are not having any problems? Every year, every 2 years, every 3 years, or only when they're having a problem? I'm proud of you again. Every year. Every year. Every year. Mammography has helped reduce breast cancer deaths, mortality, by 40% since 1990, because mammography works, and it only works if you come every year. And one study shows it cuts the risk of dying by nearly half. We don't get to pick whether or not we are going to develop breast cancer or when it happens, when it's convenient for us. We don't get to pick the type of breast cancer we're going to get if we get one, or how fast or slow it grows. And not all cancers, by the way, are the same. So I'm going to show you 3 different examples. The first example is a patient who had a lump for many, many, many years, she said. She felt it forever. And she only came in when she noticed that the skin over the lump had decided to pull in and start dimpling her skin. And at that point, she said, maybe I should come in. So she knew it was there for many years. We don't have any old mammograms because it had been that long. By the time her tumor came in, it was 4 centimeters or the size of a large walnut, okay? That's a slow-growing tumor. It had been there for many years. Next example. This patient wasn't as delinquent on her mammograms. She had been there in 2021. In 2023, 2 years later, she felt a lump, but it was a smaller lump, about the size of a blackberry, 2 centimeters. Third patient, right on time, clockwork. June 2022, June 2023, no symptoms at all. But we told her, you need to come back after your screening mammogram because she had no symptoms. We see a small mass with some calcifications. That mass was the size of a raisin, very small. So she had no symptoms, we told her. Now, what do all these masses have in common? They are all invasive ductal cancers. They're all growing at different rates. But they're all the same type of cancer. They're ductal cancers, but they're all different. Now, one's growing faster, one's growing slower. Some of them are receptive to the female hormones. The one on the right, the smallest one, the size of the raisin, that's actually the most aggressive cancer. That's a triple negative cancer, and that's growing the fastest. If that patient had not been on time for her mammogram, that would have been the size of the one on the left before she knew it, and that would probably have spread through her body. So that patient was very lucky that she came in for her screening mammogram when she did. So not all cancers are the same. The way that breast cancer grows, it doesn't grow overnight. This is a cross-section of the lining of a milk duct. And a normal milk duct has a very thin lining. And what happens is that in cancer, the lining of the duct starts to get thickened. And that's just called hyperplasia. But those cells are still normal, they're just thickened. And then when the cells become abnormal appearing, that's called atypical ductal hyperplasia. So they're not cancerous, they're just abnormal. And we can sometimes catch that and call it a precancer, and we remove that surgically. When the cells become cancerous, but they're still contained in the milk duct, that's called ductal carcinoma in situ, or DCIS, and that's a stage 0 cancer, and we're very happy we found that because that's usually the earliest stage we can find it. But once the cancer cells leave the milk duct, that's called an invasive cancer because it's invading the tissue around it. When cancer cells, in my last slide, when the other picture over there, when the cancer starts to move to other parts of the body, it hitches a ride on the lymphatic system or in the bloodstream, and that's called metastasis. So it can go other places. That's usually a worse prognosis. So this is sort of the way things work. We want to catch it in its earliest stages. Okay, so true or false? There is more than one type of mammogram, depending on whether I have symptoms or not. So this is true. There are 2 types of mammograms. There is a screening mammogram, which is when you just come and get your pictures and you go, and we'll send you a letter in the mail. And then there's a diagnostic mammogram, which is a problem-solving mammogram, which you have to stay and basically make sure that you have all the pictures that someone like me, a radiologist, needs. It might involve an ultrasound. And it's for things when you feel a lump, or you notice a change, you're having nipple discharge, any pain that's not related to your menstrual cycle, if we call you back from a screen to work up a problem, or if you're going under short interval follow-ups at 6-month intervals. So basically, the other difference is that screening, you don't need a prescription from a doctor, you can self-refer. For a diagnostic mammogram, you need a prescription from your doctor. Okay. True or false? I can skip mammograms and just get ultrasounds because I have dense breast tissue. I hear this, I've heard this quote, this is a direct quote. I am proud of your answer. False. Okay, this is a false statement because although the sensitivity of mammograms is decreased when you have dense breast tissue, it's not completely eliminated. And the thing about mammography is that it still remains our gold standard for detecting breast cancer, and it's still our only tool that has been proven to reduce breast cancer deaths. And there are certain types of cancers that will not be picked up on ultrasound, certain ones with calcifications or with architectural distortions. So we still use mammography even though we know it's still limited. And I just want to say one thing about mammography, because sometimes people, sort of gets a bad rap, but the amount of radiation with mammography is very low and safe, and it does not lead to implant rupture. Now, what is breast density? Because sometimes people don't understand what that means. It's not the way a breast feels when you feel your breast. It actually refers to the amount of glandular tissue, which is the white tissue, relative to the dark tissue. So this breast is all completely fatty, and this breast is all completely dense. And so everyone falls somewhere in between. Every breast has these 4 categories, which is fatty, scattered, heterogeneously dense, and extremely dense. And everyone actually has to be categorized into one of these types, and it's actually reported in your mammogram. And you'll notice at the top, these 10%, 40%, this is where the population falls. So 10% is fatty, 10% is extremely dense, and then the other 80% are somewhere here. And if you notice, dense breast means this category, that's 50% of the population. So if we said that 50% of the population didn't need a mammogram, that wouldn't be very helpful now, would it? So, why does density matter? Well, cancers are white. So is dense breast tissue. So that's akin to trying to spot a polar bear in a snowstorm, white on white, okay? So that makes it harder for someone like me to try to spot the cancer. And we also know that dense breast tissue is basically an independent risk factor for developing cancer. So we can't choose our breast density, that's just the way you're born, but it's important to know it, okay? So you can see that in your report for your mammogram, and also you can know if you need supplemental imaging. Now, what are those supplemental images that you can get to help see through the dense tissue? Ultrasound. Ultrasound is a great way to help where if there's no radiation required, it can see through the dense tissue. It's used for patients who are pregnant and also for young patients and for people who've had mastectomies. And it characterizes masses like these are cysts and some irregular masses. Those are actually cancers right there. And it can use as supplemental for blind spots, especially around implants. The other exam that we use for imaging is breast MRI. It's a very sensitive tool. It's great for finding cancers. It's not very specific all the time, but it's very sensitive. And we can also see a lot of anatomy this way. It's obtained with the patient lying on their stomach, and we do use a contrast. It is not for everyone. You have to have usually a higher risk, and we use it to, once a patient's diagnosed with cancer, to see how they're doing after chemotherapy, when they've had abnormal imaging, and for people who've had a personal history. So which of the following can be a symptom of breast cancer? New skin pulling, dimpling, or nipple inversion, a new lump which is increasing in size, clear or bloody nipple discharge, or all of the above. There you go. You know my all of the aboves. So any of those symptoms warrant a call to your doctor. And if you have any new symptom, please just, if you have any questions, always err on the side of caution and ask, because it's better to just reassure you than to just sit back and keep that to yourself. I'm also representing the surgeons today because I'm the breast cancer person. So I'm a radiologist, but I work closely with lots of different people who treat cancer. So for treatment after breast cancer, it is a one-size-fits-all approach. True or false? 100% false. So as I alluded to before, not all cancers are the same. Once a patient is diagnosed, they're going to hear from every single person in their realm, my friend did this, so-and-so did this, so-and-so did this, and I turn to them and I say, everyone's going to come out of the woodwork and tell you, you need to do this. They do not know your pathology. They do not know what you have. And unless they can read your pathology report, or they're an oncologist or they're a surgeon, they do not know what you need. So everything is for you, tailored to you. Everything is for that person, their cancer, their imaging, their size tumor, where it is in their breast. Everything is specific to them. And it does not include staging, by the way, it's their grade. Staging is done after surgery. And why is it so important that we catch things early? This is why. This is why. This is the 5-year survival rate for breast cancer, and look at our success with early stage breast cancer. 100%, 100%, 93%. 0, 1, 2, and then it drops at stage 4. That's because it's already spread throughout the body. This is why it's so important to catch it early. And how do we catch it early? Coming in, okay? It's a spontaneous thing that happens. It's most of the time random. It's not always hereditary. And our greatest success comes in finding it early. Although the treatments are great, and all of my colleagues in every other field that I work with have done a lot, it's here, it's me, it's my field where it matters most, finding it early. And it can only happen, I can't do my job unless patients come in, unless you come in for your screen, unless you come in for your problems and tell your doctors, because unless you guys come in, I'm useless, okay? I hope this has helped. I hope that you've learned something. I hope that you've enjoyed this, okay? Thank you.
Thank you so much. Oh my goodness, wonderful talk. Thank you so much, Dr. Burke. Next, I'd like to introduce Dr. Glenda Parker. Dr. Glenda Parker is a board-certified internal medicine physician and a USF School of Medicine clinical affiliate professor. She specializes in providing whole-person care with a focus on preventative medicine. She helps patients manage a variety of chronic illnesses and issues such as allergies, high blood pressure, arthritis, diabetes, and more. Today, she is here to talk with us all about osteosporosis, what it is, our risk factors, and prevention, as well as treatment. Welcome, Dr. Glenda Parker.
Thank you. Good morning. I'm a primary care doctor specializing in internal medicine, and I treat many women who have osteoporosis, sometimes by myself, sometimes in conjunction with my colleagues in endocrine and rheumatology. So we're going to talk a little bit more about osteoporosis this morning. Okay, so osteoporosis is a condition in which you have less bone density. So you can see here that this bone is nice and healthy, has so many bone cells, and this one over here, not so many. So this patient has osteoporosis. The World Health Organization says that osteoporosis is when you have a bone mineral density that is 2.5 standard deviations less than that of the average young female. And it can cause weaker bones and increase your risk of fractures, so that's why we care about it. Now, it's true that our bones stop growing in length after we finish puberty, but our bones are constantly remodeling. They're constantly growing in density with osteoblasts that help form bone, and then there's osteoclasts, a different type of cell that will break down bones or help reabsorb them. And unfortunately, women who are going past menopause, the first 5 years, they can lose up to 20% of their bone density. So when it comes to osteoporosis and how prevalent it is, it's kind of like how Dr. Burke was talking about with breast cancer. There are 10 million Americans who have osteoporosis and 44 million Americans who have osteopenia, kind of that in-between stage where your bone density is not normal, but it's not osteoporosis. And some of the biggest risk factors are if you are a woman over 50, and eventually everyone, we hope, is going to keep getting older, and we're all women here. So 50% of women 50 to 64 have osteoporosis in this country, and 53% over 65 do. There are certain people who also have risk because they have a strong family history. If you have a lower or smaller frame, sometimes you have less bone density to lose. And then some of our patients are on certain medications or have chronic conditions that can increase the risk as well. Okay, so symptoms of osteoporosis. Can you tell that you have osteoporosis? Unfortunately, no. It's often a silent disease, and most of the time you have no idea. A lot of us, if you have this healthy spine that's nice and straight over here, it's supporting your frame very well, but sometimes with osteoporosis, your spine is having trouble supporting your frame, and you may start to notice that you're losing height and getting shorter, or you're starting to kind of hunch over. That's called kyphosis. And then sometimes you can have an incidental finding of a compression fracture on your x-ray, say if you go in for a chest x-ray. But most of the time, you have no idea that you have osteoporosis. So how do we make the diagnosis of osteoporosis? There is a bone scan that you can get ordered from your physician. A lot of the times I talk to my patients about bone density tests at our annual physicals. And a bone scan is where it's called a dual energy X-ray absorption test, or a DEXA scan. And the radiologist will interpret the scan and give you a T-score. So what's a T-score? The World Health Organization says a T-score is your score compared to the average young healthy adult. How many standard deviations is your bone in density? So a normal T-score is -1 and above. Osteopenia, that in-between stage, is -1 to -2.5, and osteoporosis is -2.5 and lower. So osteoporosis is a diagnosis that your doctor can find after you have your bone density test by looking at your T-score. So you find out that you have osteoporosis. What do you do about it? I want to talk just a little bit about treatments. So we're going to talk about diet, exercise, how to avoid falls, and medications if we have time. I'm a big believer in food as medicine. So in order for your body to make bones and for you to have healthy, dense bones, you need the things that your bones are made out of: calcium and vitamin D. So try to make sure that you're incorporating into your diet foods that have calcium and vitamin D. And then I guess the next question my patients ask me is, well, how much do I need? It's a very personal decision that I don't want to just give you a blanket statement about how much calcium and vitamin D you need. Talk about it with your doctor, but on NIH.gov, if you look at the recommended daily allowance, if you are 50 and over, you want 1,200 milligrams of calcium a day between your diet and your supplements. And I see a little typo I did over here. Oops. You're going to want over here where it says 600 to 800, that should be over here, and then that should be down there. But so 600 to 800 of vitamin D, and then if you're under 50, a little less calcium and vitamin D are needed. So, and the reason that is because the average age of menopause in this country is 50. And remember, we talked about earlier how menopause is one of the greatest accelerators of osteoporosis. So I said between your diet and your supplements, are there any risks to taking supplements? Can I just take supplements and not worry about my diet? No, I still want you to kind of get an idea of how much calcium and vitamin D you're getting in your diet. Maybe write it down in a log every day for a couple of days and figure out about how much you're taking, and then make up the rest in your supplements, because there have been some concerns about are supplements safe. So I've looked at the research. There's no risk for taking calcium supplements up to 1,000 milligrams a day for increasing your heart mortality. So go ahead and get up to your 1,000 milligrams a day for your calcium. But there might be some risks related to kidney stones, and the supplements themselves can have some interferences with certain medications you might be on, like if you take thyroid medication. And sometimes if you take too much calcium supplements or D supplements, you might have problems like constipation. So it's important to look at both the diet and the supplements. Okay, so exercise. Exercise is one of the things my patients will probably tell you I nag them about the most, because exercise is going to be good for you from a heart standpoint as well as for your bones. And so when we talk about exercise, I want you to do cardio with weight bearing, 30 minutes most days of the week, and it could be walking, jogging, dancing, something that's gonna put some weight on your bones. In addition to aerobic exercise, you wanna practice posture awareness every single day. So not this, okay? That's gonna be healthier for your spine. Also, there are posture exercises you can do 2 to 3 times a week. This is an example from Bone Health and Osteoporosis Foundation on a simple posture exercise that you can do. In addition to posture exercises and cardio, I want you to do hip and back strengthening exercises a couple times a week. And balance exercises daily. So if you have osteoporosis, incorporating balance exercises, strengthening and posture awareness, as well as your cardio with weight bearing, that's gonna help treat your osteoporosis. So that's a lot, right? So that's why I'm a big fan of yoga and Pilates for my patients. Just be sure if you're using yoga or Pilates for balance, as well as cardio, as well as strengthening, and posture, that you're looking at poses that are going to help keep your spine straight and not the ones where you may be bending forward. Remember, most compression fractures occur on the spine when you're in a forward-leaning position, so keep your spine straight. And these are just some poses of safe Pilates versus not safe Pilates, and safe yoga versus not so safe yoga. Okay, so coming up with your own exercise plan, it might seem a little intimidating. There are lots of good videos online, and this is a website I recommend where you can get some more information about exercises that can help you for osteoporosis. And then this one, Too Fit to Fracture, is an interactive site that you can go to that's going to help give you information on strength training, balance exercises, aerobic activity, and tips for addressing barriers for your exercise. After all of that, if you're still struggling to come up with exercises that you can safely do, talk with your primary care doc. That's what we're here for. And I may even refer you to physical therapy so that you can work with a therapist to help you with strengthening and training and balance exercises. Okay, decreasing your fall risk. This is really, really important too. My mom in 2020 fell and broke her right hip. And then this summer, she fell and broke her left hip. So we really, really want to prevent falls because when you fall and you break your hip, it's such a hard recovery. So it's definitely doable, but if an ounce of prevention is worth a pound of cure, right? So make sure that you're thinking about avoiding excess caffeine and alcohol, especially at bedtime, because that can increase urinary urgency and frequency, getting your vision checked every year, avoiding fall hazards, avoiding sedatives and hypnotics and sedating medications at bedtime, which can increase your fall risk, clutter, things you can trip over, and then something that you can have some grip to in the bathroom when it's slippery and wet. Okay, so we talked about nutrition, we talked about exercise, we talked about preventing falls in the first place. After all of that, though, there are some patients that I still need medications to help treat their osteoporosis. So it's a personal decision. You shouldn't go at it alone. You and your doctor should talk about what is your age, what is the severity of your disease, what's your T-score, what's your frame, and taking all of that into account, we can decide if you need a medication. And there's several different types of medications. Sometimes you may come in and you have your mindset, I want this medication. But there are benefits and not benefits associated with each type of medication. So I'm just gonna give you a little bit about some different classes of medicines, but I really want you to talk to your doctor about the different medications out there for osteoporosis treatment. I'm starting with bisphosphonates because they are probably the go-to that most people start off with. They work by helping prevent bone resorption or bone breakdown, and studies show they reduce your vertebral and hip fracture risk. They increase your bone density. They're not going to increase your risk of blood clots like DVTs or PEs, and they don't increase your risk of cancer. But they're not for everyone. You can't take them if you have certain esophageal disorders, chronic kidney disease that's of a certain severity, or I don't use them on my bariatric surgery patients either. These medicines are the least expensive, and I have no problem getting them covered by your insurance company. And then I put this little picture of Sally Fields up here, because we've probably all seen her commercials for Boniva. There's several different types of bisphosphonates on the market: Fosamax, cylindric, orizindronic acid or Actonel, Boniva, and Reclass is actually an infusion that you can have once a year. If you can't do a bisphosphonate or a bisphosphonate doesn't work for you, a lot of my patients take Prolia. It is a twice-a-year shot or every 6 months shot. And like the bisphosphonates, they are going to help increase your bone density and decrease your fracture risk, and it also helps with fracture-related bone pain. So if you have had a fracture and your bones are hurting, it can help with that as well. But the problem with this medicine is pretty expensive. So you may find that some of your insurance companies aren't going to cover this one unless you try the bisphosphonate first. There's medicines, I don't use these that often. It's only a specific type of patient that I'll use this one on, a selective estrogen receptor modulator. And the reason why is they just aren't as effective as the bisphosphonates. But there are certain patients that this is a good medicine for. And then I didn't start off with this, but you're probably asking yourselves, well, why don't we just take estrogen? Because you said menopause, and after menopause, the first 5 years, you lose so much bone density. We used to give estrogen out a lot more than we do now, but about 2 decades ago, there's this big study called the Women's Health Initiative, and I'm a big believer in evidence-based medicine, so we want to make sure that we're not causing harm when we give our patients certain treatments. And what we found with the Women's Health Initiative is that when you take estrogen, sometimes you need estrogen, but when you just take estrogen, there can be some problems associated with it. So an increased risk of venous thromboembolism or DVTs and PEs, possibly affecting your risk of breast and uterine cancer. Remember, Dr. Burke was talking about how certain cancers have certain female hormone receptors. And then there are studies that show an increased risk of coronary artery disease. So estrogen is not for everyone, and we don't recommend it. You have to be very cautious, and it's not a first-line treatment for osteoporosis. However, if you are on it, you will find that estrogen will help increase your bone mineral density, relieve your hot flashes, and your vaginal dryness. Okay, last one. This is what my mom is on. Remember, I told you she has the severe osteoporosis with 2 hip fractures. There are some patients who have severe osteoporosis who can't take bisphosphonates, and this is a medicine that, unlike the other ones that helps prevent resorption, this medicine helps with bone formation. The downside of this medicine is, very expensive, and it's a daily injection. So that was a lot. I gave you a ton of information about medications, but if you're interested in more information for osteoporosis, go to National Osteoporosis Foundation, cdc.gov, Bone Health and Osteoporosis Foundation, nia.nih.gov, Cleveland Clinic, or if you're thinking about the costs of these different medicines, goodrx.com. And that's it. I finished on time.
Thank you so much. Thank you so much, Dr. Parker. I'd like to introduce our keynote speaker, Dr. Layla Durr. She hates to be introduced. Dr. Durr is a licensed psychologist and the director of provider well-being for Advent Health Medical Group's West Florida division. She's passionate about promoting wellness, self-care, and resilience by offering individual counseling, consultations, workshops, training. As a psychologist, she approaches therapy from a strength-based lens and believes in the power of the individual to make changes in their lives once they have taken the time to reflect and gain self-awareness. Today, she's here to talk to us about the importance of women's mental well-being. Please help me in welcoming Dr. Durr to the stage.
Thank you for that introduction. My name is Dr. Layla Durr. I am a psychologist, and I work with our physicians most of the time. So I want to start off. Now, you can just think about this as you are eating. If you've got place in the notes that you want to actually do this activity, I will encourage you to consider it. But reflect on what's on your plate of life, right? Not what's on your plate of food in front of you. What's on your plate of life, right? What are the roles and responsibilities and relationships that tend to drain you, that tend to cause you stress or distress? What are the roles and activities and relationships that tend to fill you up and nourish you, that contribute to your well-being? As the introduction stated, I work with physician and APP well-being. So I am constantly challenging our physicians to reflect on what they are doing that can help contribute to more wellness. And when I've done this activity with them, some of the things that I realize and that I hear is most of our physicians, especially most of our women physicians, will tell me, well, I don't have time for me. I've got my patients to take care of. I've got the community. I've got my team that I work with. I've got my family. I've got my neighbors. I've got all these people that I'm constantly taking care of. I don't have time for me. Right? When you look at that plate, there's probably things on there that really do nourish you, but those don't take the biggest portion of your plate, right? Those sometimes are sitting on the fringes, barely hanging on your plate, kind of like the cookie that I forgot to grab. The things that sit in the center tend to be the things that really tend to weigh you down, things that take the bigger parts. So my challenge often is for us to really look at what's on our plate and figure out what are the things that we want to grow on our plate, to help to strengthen us, because they are the things that fuel and nourish us. And what are the things that we need to, keep them in check so that they're not taking over our entire plate. All right, so before we dig further, let's define some terms. Right? What is well-being? Well-being is a combination of feeling well and being able to function well, right? In simple terms, it's the ability to do stuff, to get things done. It is a balance and harmony of your body and your mind. What is stress? Stress is a very normal part of life. And it doesn't have to be bad things that cause us stress, right? A promotion can be stressful. I saw a couple of children. Dr. Armenius was talking earlier, and her son was in the back kind of making noise. That was probably, a child is stressful. I have two of them. They're handfuls. Things like buying a house or even going on vacation can be stressful, right? So even positive things in life can be stressful. So stress is a normal part of life. Stress is the body's reaction to any change that requires a response or an adjustment. Any change, positive or negative, right? And sometimes that stress fuels us, right? If I wasn't worried about missing my flight, how often would I actually get to the airport on time? Right? What is distress? Stress that continues, that is severe, prolonged, or both, and continues without relief can lead to distress. That is the negative stress reaction that can happen, right? And you've already heard a number of conversations today of the way that distress and stress can disturb the body's internal balance and equilibrium. This is why mental health and stress can lead to physical symptoms and physical illnesses, like things related to your GI, your cardiovascular system, migraines, as well as emotional problems, weight problems, right? All right, let's talk about what mental health is. Mental health includes our emotional, psychological, and social well-being. Our mental health affects how we think, feel, and act. So any disorder that will affect one's mood, thinking, or behavior is considered a form of mental illness. Okay. How we handle our stress is part of our mental health. I will try to go through these not exciting facts and figures quickly, just because I want to get to the fun stuff. But 1 in 5 US adults experience mental illness. These are statistics based on 2020. So this was even pre-pandemic. I don't think NAMIS has had a chance to even run statistics since then. 1 in 5 US adults. Globally, it's 1 in 4. Okay? 1 in 20 will experience serious mental illness. That's huge. And 17% of youth, 6 to 17 years of age, experience a mental health disorder. That number is so on the rise, especially since the pandemic. Specifically for women, right? In 2021, the prevalence of mental illness was higher in women at 27% than males at 18%. Now, some of that could have a little bit of reporting, right? Women might be more willing to talk about their mental health challenges than men are, how we are gender socialized in that sense. Men, I have to be strong in a different way. There are some disorders, though, that are more common in women. Depression and anxiety are 2 times as likely to happen in women than in men. They tend to be those internalizing disorders. We take it inside and we just, right, like mess with it on the inside. Eating disorders tends to be more prevalent in women than in men. Sorry to mention that while you guys are eating. All right. Men tend to have higher rates of disorders related to impulse control and substance abuse, because they tend to externalize their stress rather than internalize their stress. There are also some disorders that are unique to women, right? Anything related to hormonal changes, reproductive health. Men don't have to worry about PMS or postpartum depression or postpartum anxiety. I mean, some of them will experience some of that postpartum, but it's not postpartum related. It is just new parenthood related. Okay. But also, the other reason that some of this prevalence varies is that women are more likely to experience some of the following risk factors: higher poverty rate, lower earning rate for doing the same job, more likely to be victims of sexual or physical violence, and 65% of women are the primary caregivers, not just of their kids, but of aging parents and other family members. So all of those contribute to that. Have I depressed anyone yet? All right, let's look at a few other things about stress in women. There is a huge expectation in women that we can do it all. We can manage work, we can manage family, and on top of it, we're gonna be super mom. I've heard it said, and I really need to figure out who said this, that women are often expected to work as if they don't have a family or children, and to parent as if they don't have a job. What? Like that is just, that makes me angry. But right, there's an invisible load on mothers that exists out there, right? There's things that again, this is generalities. There are a lot of parents and a lot of fathers that are very involved, but there's some things that moms are constantly just keeping in the back of their mind. Women tend to have the second shift and the third shift of house duties, parenting duties, right? All of those things is some of the unpaid labor. So if women on top of it also have a paid job outside the home, you've got 3 full-time jobs as women if you are also moms. No wonder you're exhausted. So what can we do about it? Well, we could be like Linus and just stand there and cry. Or here are my tips and my strategies that I would recommend. One is making you a priority. You've heard it said, right? If the oxygen mask drops, put it on yourself before you put it on your children. Let me tell you guys, I have twins. And when they were babies, I actually tried traveling cross country a few times between California and Florida with them. I don't know how many flight attendants were like, yeah, okay, but you have to then choose which one you like more. And I'm like, I'm gonna smack you. Like, don't tell me I have to choose which one of my children I love more. Because what I'm probably gonna do is the masks are gonna come down and I'm gonna put them on the kids and I'm gonna say, forget me, right? But that was their whole point. It's gotta go on you first. I can't be of any good use to my children if I don't take care of me first. I say this to my doctors all the time, right, ladies? Whether it's for your family, whether it's for your patients. So you have to make yourself a priority. Know who you are and know what matters to you. What are your values? What is your purpose for what you do? Right? What are the values and priorities that you have in life? And then prioritize them. How do you do that? You write them down first in pen, right? I'm dating myself here from the days of like an actual paper scheduler. But when you write them down first in pen, like what are you writing down? You're writing down, okay, this is what time I'm going to bed because I have to wake up at this time every day. Because I need 7 to 8 hours of sleep, right? Dr. Witten told us that this morning. I'm writing down, I need to exercise every day in some sort of physical activity. So where am I doing that? I'm writing down, these are the breaks that I need for the day, right? You're right, though, I'm writing down date night if I want that, right? So you write down your priorities for you first. And yeah, you put them in the places that work around your work schedule. You're not gonna say, I'm sorry, I have to work out at like, 10 a.m. every day if your work is not conducive to that, because then you won't end up with a job, right? And then when I say in pen, is because you don't erase them. It can be an erasable pen if you really want to be able to be flexible, and it's okay to be flexible. If you don't work out at 7 a.m. because your kid wakes you up 3 times that night and you're exhausted, all right, well, when am I gonna do some sort of physical activity today for my health and my mental health, right? And then you create margins. I don't know how many times people pack their calendar and forget about the transition time from point A to point B. Okay, I'm gonna have this meeting and then I'm gonna get the kids from school and then I'm like, oh wait, I have to drive from my office to the kids' school to be able to get them from school in between. That doesn't work, right? So margins. A little wiggle room in case of traffic. We do live in Tampa, there's lots of traffic. And then step 3 of making you a priority is protect you as the priority. Set boundaries and learn to say no. Each of you, turn to somebody sitting next to you and say no. Right? Now, I know we're laughing about this, but it is not easy to say no. It is not easy for women to say no. Come on, please. No. Right? And no is a full sentence. But there are other ways, right? You can say other ways of like, I am committed to something else at that time, I'm sorry. You don't have to tell anyone what you're committed to. You don't have to tell anyone that you're committed to is a bubble bath, right? Or spending time with your kids uninterrupted, or going, right, for a walk and walking the dog. And you are committed, you have prioritized yourself. But you think, so one thing I've often told my physicians is also, it's okay to say, you know what, let me think about that. Somebody's asking you for something, let me think about that. It buys you time to decide, is this important enough for me to move some things around, or do I need to strategize how I'm gonna say, thank you for that invitation, but no. Right? The only person that's not allowed to say no is my mother when I ask her for help. Keep in mind, guys, that why is it so important to do this? Because there is a strong link between women's mental health and wellness and that of your children, your family, your work, your colleagues. Like, it feels to a lot of us that we are the center of the world and the world revolves around us, but it kind of is to your family oftentimes, right? I don't think my husband helps in so many ways, but I don't think he would have any clue about how to keep all the appointments for the kids in check and things like that. And like, what time do they actually get out of school on what day? Because there's early release and all that, like. And so your health is important, and your stress affects all others. So besides thinking about others, if that's what you want to do so that you don't feel selfish, right? If you take care of you, then everybody else will be healthier. My daughter would tell you that is true, because if I stay good and healthy and stress-free and calm, then I'm not triggered by my children as easily, right? But the other piece of it is that you've already heard a number of talks, and you will hear more about the impact of stress on your physical health, on your sleep, and vice versa, on your weight, and vice versa, right? Okay, step 2, make your wellness a priority. What is wellness? Wellness consists of kind of like what's talked about often as the wellness wheel. Physical self-care, mental health, social wellness, spiritual wellness, occupational wellness, intellectual wellness, all of those components. I thought this quote was great. You owe yourself 1 hour a day of self-maintenance. It can be reading, writing, yoga, exercise, dancing, meditation, painting, I guess I could look at it down here, or whatever. But you owe it to yourself. 1 hour, 1/24th of your day. That is less than 5%. And it really does matter. So when you put it in that perspective, how many of you guys actually give yourself 1 hour of your self-care in a day? Okay, I see a couple of hands, good. And it can consist whatever it is, right? If you're driving on the road with a wheel, with one of the wheels on your tires has like a screw or a nail in it, and it's like deflating on one side, eventually you're not gonna get very far. It's the same thing with your wellness wheel. If one area is struggling, eventually your entire wellness wheel, your entire system is going to struggle. I forgot my phone, but I love this acronym. I have to use a lot of acronyms with our physicians because they use a lot of these kinds of things to remember the 5 gazillion pieces of like information they cram in their heads during medical school. But attending to your self-care is like taking a selfie. So when you take a selfie, right? You hold it up, figure out the best lighting, my best angle, make the chin, right? Like I am constantly, if I take a selfie, because I don't, but I am constantly checking in to make sure that it is gonna be Facebook worthy. Because why would I take a selfie if I'm not gonna put it on something, right? But I'm paying attention to every angle that matters to me. How often do you take a selfie about your self-care? How often do you stop and think, have I gotten enough sleep lately? Have I gotten any physical activity, right? And it doesn't have to be all or nothing, an hour at the gym or nothing. It can be, whoever it was that talked about it, parking further away, right? Park in the shade somewhere further away and walk, right? 15 extra minutes. I tell a lot of my physicians, just get home, grab the dog or just grab another pair of shoes, take a lap around the neighborhood, just use that to like get 15 minutes of walking in, but also decompress from work and be ready to be at home, right? Have I gotten any light, right? Dr. Ross, you're a surgeon. You're in that OR with very little light most of the time. Natural light is important for us, for our mental health and our physical health, right? What kind of fun have I done? God, how have my interactions been lately? Have I connected with anybody that matters to me? If you work, you need professional colleagues that you can connect with that understand your world, because sometimes your family doesn't. And you need personal colleagues and family members that understand that part of your life and can just support you no matter what, right? It's important to have those interactions. And then, of course, eating healthy. So, right, keep calm and take a selfie. Make sure that you are doing that self-check, right? Dr. Burke did not talk to us about doing the self-breast exam kind of stuff, but do a mental health self-check. Take your selfie. Figure out what works. All right. And then I have 15 seconds. Other things you can do is strengthen your resilience, right? When oh my God, I just forgot her name. The doctor that was talking about osteoporosis, right? Thank you, Dr. Parker. When bones are strong, if I fall off here, if my bones are strong, I can withstand that fall probably and I won't break my hip. But if they're not, if they're brittle, right, I could hurt myself. That is what resilience does. Resilience does not prevent you from facing a stupid fall like I might do, or life, because sometimes the fit does hit the shan in life, right? Resilience helps to strengthen you so that you're able to withstand it better. I like the image of these shells, right? We are here in Florida. We live close enough to the beach where we can sometimes find these really cool shells out there. Each of them is different, but they're all really beautiful. But the beauty of those shells was forged by them getting beat up by the waves and the sand. That's how they got to have the colors that they did. It's not just by sitting there being pretty like on the sand, right? They took their abuse and that's what made them pretty. And oftentimes that's what happens for us with adversity. Adversity can strengthen us and give us what's called post-traumatic growth, right? And make us more resilient and more beautiful, but we have to kind of weather through it. So there's different things that you can do. Those are the resilience things. Mindfulness strategies are a great one. Breathing techniques. Putting one hand on your belly, one hand on your chest. Making sure that it's the belly hand that is moving. That is a deep breath. This is not a deep breath, right? That is a deep breath when my belly's moving, right? Muscle relaxation, your 5 senses, grounding techniques. There's so many apps out there that you can do, like, I'm not trying to sell them, but like Calm and Happy Play. I don't even remember some of them right now. Gratitude. Gratitude is one of those really cool resilience strategies that is the simplest way to turn on positive emotion, right? And it's got a lot of benefits that come with it. The important thing, and there's different ways of doing it, right? You can do gratitude through a gratitude journal. You can do gratitude through things like a gratitude board in your house or at work, where people just write down things they're grateful for. You can write gratitude letters to people, right? Different strategies. One thing that is said is that feeling gratitude and not expressing it is like wrapping a present and not giving it. What's the fun in that? So, right, because when you express gratitude to someone else especially, not only does it help them, but it actually helps you even more than just feeling it. All right, I would be remiss if I did not point this out as a psychologist. If you're experiencing excessive stress or any mental health impacts, it is not a sign of weakness, right? But if your symptoms last for 2 to 4 weeks or interfere with your relationships, your work or daily functioning, or you need to seek care. There's different ways of doing it. There is the suicide prevention hotline, which has been last year, I think, switched over to 988, so the mental health hotline of, counterpart to 911. There's a crisis text line. Reach out to a therapist, right? Okay, I am totally over, so there's no time for Q&A. If you have any questions, I'll be around. So, thank you.
Thank you, Dr. Durr. That was definitely well accepted and needed. Let's kick off our afternoon sessions with Dr. Sharona Ross. Yay, Dr. Ross. Dr. Ross is an advanced foregut, biliary, and pancreatic surgeon, specializing in robotic and single-incision laparoscopic operations for disorders of the esophagus, stomach, small bowel, pancreas, and gallbladder. She was recently announced as the nation's leading surgeon for robotic Whipples, helping our Digestive Health Institute Tampa reach the title of #1 robotic surgical program in the state. Yay. She's here today to speak with us all about acid reflux and how to prevent esophageal cancer. Welcome, Dr. Ross.
It's perfect timing to have a talk about acid reflux just after lunch. How many of you have acid reflux or suffered from acid reflux? Well, many of us. I mean, it's to a certain degree, it's normal to have it after a large meal. But what we're going to talk about is when is it not normal? When should you seek some help? First, we're going to start, what's the anatomy of the esophagus, stomach? What are the things that are happening? So first of all, you have the esophagus. The esophagus propels food in one direction. If you have normal motility and you just ate and stood on your head, the food will still go into the stomach. There is then between the esophagus and the stomach, there's a lower esophageal sphincter that's supposed to relax when you eat to allow the food to enter into the stomach, but then it's supposed to constrict in order to prevent reflux. Why are we talking about this now? Is because esophageal adenocarcinoma has become an epidemic in the US because of morbid obesity. But it's not only, you don't always have to be overweight to suffer from reflux. You may just be I have young guys that are coming with reflux. That's because they bench press such heavy weight that they increase the pressure in the core, and that causes reflux, right? So because of the increase in esophageal adenocarcinoma, that's when we talk about chronic acid reflux and the important treatment of reflux. Otherwise, you will have the risk and live with the risk of esophageal cancer. Now, it's one of the very few that we can actually prevent. How many cancers do we know that we can absolutely avoid altogether? You treat chronic acid reflux appropriately, you eliminate esophageal adenocarcinoma. And this is what happens. The sphincter, as I mentioned before, if it appropriately works, nothing, the acid and the bile are never going to reflux into the esophagus, right? Now, the acid in the stomach is good for the stomach. I mean, our body is an amazing machine. It produces the acid, it can handle the acid, but not the esophagus. You would think everybody's familiar with heartburn, regurgitation, but the physicians that send majority of the patients for reflux operations are not the gastroenterologists. You would expect that they would, because gastroenterologist who starts the medication, right? But it's the pulmonologist, because patients have a difficulty breathing with exacerbation of asthma or any pulmonary symptoms. It's the cardiologist that people present with chest pain and they think they have a heart attack, and no, they have reflux. It's the dentist with enamels that are eroded because of the chronic acid reflux. And it's the ENT, because patients come and they're hoarse, they're always hoarse. Well, the acid keeps on bathing the vocal cords and causes this hoarseness. And those are the people that have significant reflux. And by the way, almost 50% of the patients that develop esophageal cancer never had the symptoms of reflux because their esophagus was not even sensitive to it. So, how can you diagnose reflux? That's easy. You do an upper GI, you do endoscopy, the scope, and we'll talk a little bit about that. Bravo pH is the only objective study we have to document whether you have significant acid reflux or not. And then we have manometry, which tells me the motility of your esophagus. So when patients come to my clinic, I always end up talking about weight loss. And because majority, not all, but majority of people that suffer from reflux, as women, pregnancies, and sometimes nobody likes to do sit-ups and core exercises, but sometimes that's what is necessary. But it's especially the supersizing of our meals. We all want to sit here, and now we're feeling a little bit of reflux. Then we take Tums, and instead, when you distend your stomach, what happens is your sphincter is being relaxed, and you're more likely to have the reflux. And so the best thing to do is initially, to make sure that that is the problem, you first want to do some lifestyle changes. So on the one hand, you don't want to eat the fattening food, but at the same time, don't eat late. And sometimes elevating a little bit the head of the bed would help. What are the things that we really like to and enjoy eating? And I didn't look at what we had outside, but I guess it's a good thing. But how many of us consume these? But what we should be consuming is this, right? I even don't let people that they have reflux eat salmon because it's a fatty fish. And if you're trying to lose weight relatively quickly, because by the time we know that you need an operation, we want to do it relatively quickly, which means within a few months. So when it comes to the sphincter, which is relaxed, that's why you have the esophageal reflux, we talked about what causes this, distending the overall volume of the stomach. Some people will say, well, my stomach doesn't empty. Well, it's not that it's not empty necessarily, unless you have type 1 diabetes, but it's more the pylorus is working well, it's good pressure, but the lower esophageal sphincter is more relaxed. Path of least resistance. If you have your stomach is full, it's not going to go through the higher pressure, it will go up through the lower pressure system. So what do we do after a large meal? We don't say, oh, next meal, I cannot eat a large meal anymore because I suffer from reflux. No, we just eat some Tums, chew on those, take some H2 blocker, take some PPI. But remember, when it comes to PPI, they were approved by the FDA for only 11 weeks. But as American Association of the Gastroenterology, 4 to 8 weeks. They're not to be taken lifelong. Now, when they came out like 30 years ago, it was like the magic pill because the operation we had to offer was open operation, right? Through the chest, through the abdomen. But people got those medications, the symptoms pretty much went away. So they was like, wow, I'm cured. Well, almost 30 years later now, we realize that you're not cured. And in fact, when we stop the production of acid in the stomach, what we do, remember, our body is an amazing machine. It's very smart. It's very selfish. If you're supposed to have acid in your stomach, that means it has a purpose. Why do we talk about the complications or the side effects of those medications? Because when you remove the production of acid with this medication that is most effective, you don't absorb certain vitamins and certain elements. So people start to have, they can break their bones because they have osteoporosis. Even men that use that for years can have osteoporosis by the age of 50, which you rarely hear. You can have dysrhythmia with the heart is now because you can't absorb magnesium. They're associated with dementia and kidney disease, and there's so many other, and we'll get into that in a second. But it's not supposed to be taken that for that prolonged of a time. So how many of you are having those symptoms once or twice a week? How many of you having it once or twice a day? Okay, you can have lunch. The majority don't have it, so that's perfect. And what I mean when you don't have it, that means you never necessitate even Tums, because if you need Tums, that means you have it. So when I tell my patients, I say, do you suffer from blood pressure, high blood pressure, diabetes? I said, no. Well, it's controlled. So they don't see it as they're suffering from it. But if you're taking medication for blood pressure, that means you have high blood pressure. But in general, with reflux, many people suffer, even people that you know. When is it considered mild symptoms? Once or twice a week, because most people will have once a month symptoms. That's not bad. Once or twice a week, that's not so good. Once or twice a day, that's really bad. So something needs to happen. Those are just more of a list of different side effects from the acid reflux medication, specifically proton pump inhibitor. And many times you do scopes and you're for people that use it for more than a year or so, you start to see all those polyps in the stomach. When you stop it, they do go away, but you never know if one of them will become cancerous. So why are we worrying about this? Well, when you have this progression to esophageal cancer, that's what happens. You first have the irritation. The esophageal lining is not supposed to have exposure to acid or bile. So when you stop with those medications, the acid production, you do nothing to bile. That's why patients, even that are treated with anti-reflux medications, still can develop cancer because it does nothing to bile. And that is the problem. And so you have all those changes in the mucosa to Barrett's, right? The lining of the stomach is a certain lining that can handle acid reflux. The acid content, as it goes up into the esophagus, the lining changes. That's the Barrett's esophagus, and then it goes to dysplasia and ends up with cancer. What is Barrett's? Everybody hears about Barrett's. Well, it's, as you saw, it's in the process of becoming cancer along the lining of the esophagus. And why is it important? Because 30 to 40 times increase, that's what happens when you have Barrett's to develop esophageal cancer. And we all know that that's a predisposition, puts you at a higher risk if you have Barrett's to develop esophageal cancer. And in fact, we've seen increase in esophageal adenocarcinoma, as I said before, which is completely associated, directly associated with acid reflux, chronic acid reflux. We saw an increase in 56 folds, not 56%, 56 times increase in the incidence of esophageal adenocarcinoma. That's why it becomes a problem. And when we look over time, adenocarcinoma of the esophagus increased in the incidence while the squamous cell carcinoma is decreased, because squamous esophageal cancer is associated more with smoking and drinking and having a good time, right? We have a decrease in those amounts, but increase in esophageal adenocarcinoma. So what should we do? What are the things that we can be tested for in order to know, are we having significant amount of acid reflux that will necessitate an operation in order to remove that risk of ever developing esophageal cancer? Well, those are the tests. First one is EsoGuard, which is quite new. And it's an office procedure where the small little catheter with a balloon at the end, that there'll be a nurse that shows you how to swallow it. Then she inflates the balloon, takes some samples of cells from the end of the esophagus, and then send it to the lab. And within 2 weeks, you get an answer whether there are any DNA changes that are consistent with Barrett's esophagus. So that's an easy 3 to 5 minute test. You don't need to get under anesthesia and take a day off of work. It just very quickly can be done in a clinic. Endoscopy. In endoscopy, the gastroenterologist will put a scope in, and you can look for esophagitis, which will be showing us that the lining of the esophagus are bathed by acid. It can show even stricture, narrowing from chronic acid reflux, and then cancer. Those are the pictures that document all of them. We talked about manometry. This is first the Barrett's. I have 2 screens here, so I have to remember one is the next one. The Bravo pH is a little chip. It's the only objective study we have to document if you have significant acid reflux or not. It's a chip that the gastroenterologist will place about 6 centimeters above the GE junction, the end of the esophagus, beginning of the stomach. It's going to stay there for 48 hours. To some places, we'll keep it for 72 hours. And objectively, it will measure how many times the content of the stomach reflux to the esophagus, how acidic it is, and how long does it stay bathing the lining of the esophagus. You'll be carrying a pager for that time, and what they'll do, they'll show you where to push the button, press the button when you feel certain symptoms like heartburn, regurgitation, etc. And then when you bring back that pager, they'll associate what you felt with what actually happens. And it will give us a DeMista score. A DeMista score that is around 14.7 or higher, we know you have significant acid reflux and you will benefit from a procedure. It's a mechanical problem that should be fixed mechanically. Like I said before, medications only help with the acid at most, does nothing to bile. Bile is just as carcinogenic as acid. So manometry, what is manometry? It's a study that is least favored by most patients. It's a catheter that they have to swallow, and then it takes the pressures along the esophagus. So it tells us, differences between reflux and achalasia, which is a whole other disorders, but also the motility of the esophagus. So it guides me with the future, if a patient needs an operation. Upper GI, we usually do with a bagel and marshmallow. It gives me a nice silhouette of the esophagus and stomach. If there's a reflux, it shows me that the stomach is up above the diaphragm. but it also will show me how is the esophagus handles food bolus with a bagel, and after that with a marshmallow. And then they'll put the patient in Trendelenburg, and then see how the esophagus is handling the bagel, and after that, marshmallow. One or two type of a sweep or peristalsis, we know you have good motility. However, if it's more than 3 or more than 5, you not having great motility, and it will aid with the decision of what you're going to need for reconstruction. So as I mentioned before, it's a mechanical problem. So if you have significant acid reflux, medication can prolong it, but the risk for esophageal cancer is still there. That's why I offer the operation. So you have to fix a mechanical problem mechanically. So how do we do that? As you see in this picture, the stomach is going above. It lives now above the diaphragm. Usually you have the esophagus, and then there's an opening in the diaphragm that allows the stomach to be there as well as the distal esophagus. Now what happens with an increased pressure here, things are being pushed up. And so what we do is we'll bring the stomach down. That's how we repair the hiatal hernia. We bring it down and then close that opening in the diaphragm so it will be nicely snugged around the esophagus. And that's the hiatal hernia part of the operation. You see how it's sutured. Okay, so what do we do next? How do we do the anti-reflux component? Well, if you have normal motility based on the manometry and the upper GI, then I would do a Nissen fundoplication, which is a 360-degree full wrap around the esophagus. I don't take any foreign bodies. I just use your own stomach on the top and put it, design it around the esophagus so there is increased pressure at the end of the esophagus, beginning of the stomach, preventing reflux or acid and bile from refluxing into the esophagus, as you see here. What if you don't have great motility of the esophagus? What if it takes a lot of waves and you're still not pushing the food bolus into the stomach? Well, then we do a partial fundoplication, which is a toupee fundoplication. So in other words, the posterior fundus that I bring behind is not going to be sutured into the anterior fundus. If you have chronic acid reflux, I bet he's not suffering from reflux, I don't think. It's too young. You have to worry about esophageal cancer. Chronic acid reflux should be treated appropriately. Majority, however, of the esophageal cancer are never really reached and identified by, when they're tiny little dot in the esophagus, in the lining, because they give you no symptoms. But they are being diagnosed when your patients can't eat anymore, or they cough blood, and it's always much more traumatic. And so then they have to be started on chemo and radiation before they even get to an operation. So it's all preventative if you treat yourself to first lifestyle modifications. If it doesn't help, get more evaluations, objective evaluations, and then insist to see somebody other than your primary physician to get a consultation. And then you have all the information, you can make an informed decision regarding your health care. This is what I don't wish on anyone, which is when you do develop esophageal cancer, well, I don't wish it on anyone, but if you had to have esophagectomy, I would prefer to do it robotically than open, because it's really morbid operation. That's when we take the entire esophagus out and bring the stomach behind the heart, over the aorta, all the way to the neck, and connect it to this much of esophagus. That's the operation. Now, to do this operation, I do with 4 incisions, small incision, and a small incision in the neck. But it's morbid. It's avoidable. So if you have 2 or more heartburns per week, or definitely if you have 1 or 2 per day, if you have any of the atypical symptoms, be seen. Demand to see somebody and objectively be evaluated for reflux. Ask to go and see the gastroenterologist, and then if the studies are not normal, demand to see a surgeon. Anyone that will give you a consultation and then make the decision as to your health care. One of the main goals for me to treat this disease is to prevent esophageal cancer. So at a year after surgery, I always repeat the Bravo pH, because most patients will say, oh my God, my symptoms are gone. But I want to make sure there are no silent reflux there. So we completely eliminated the risk of esophageal cancer. Thank you.
Thank you so much, Dr. Ross. Next, we have Dr. Kim Nguyen. Dr. Nguyen is board certified in colon and rectal surgery and general surgery. She performs minimally invasive surgery using laparoscopic and robotic techniques to treat colon and rectal disorders, with an emphasis on individualization of care. Dr. Nguyen provides medical and surgical care for various diseases that affect the lower gastrointestinal tract, with a special focus on the optimal treatment of colorectal cancers, as well as benign conditions such as ulcerative colitis, Crohn's disease, diverticulitis, and anorectal disorders. Dr. Nguyen is an active member of the American Board of Surgery and the American Board of Colon and Rectal Surgery. Today, she's sharing with us the importance of colonoscopy, screenings, and why we shouldn't sweat the prep. So welcome, Dr. Nguyen.
All right. Thank you for that introduction. Thank you for the opportunity to speak. So Dr. Ross started from the top, so my talk will end at the bottom. And so we'll talk about why we do colonoscopies in the first place, right? The purpose is to prevent cancer. Colonoscopy actually is the only method of preventing cancer. You have other methods of screening, right? Testing your blood, your stool for blood, doing the Cologuard. Yes, you can do that, but if those are positive, what do you end up doing? You end up getting a colonoscopy anyways. So usually I promote the colonoscopy just because maybe it's rare, but when it happens to you, I usually say it's not rare, right? It affects you personally. It's you who have the cancer. And I've seen cases where there are individuals who've been very, done the Cologuard or the fecal occult blood test, and they end up with cancer anyways. So usually, we'll talk more specific about the colonoscopy procedure itself. But here we have the ending of the GI tract. I usually say it's one long tunnel, begins with your mouth, ends at your anus, right? And so the colon, you have it starts on the right, goes across your belly, goes down the left, and ends in your rectum. And then this is what we're trying to prevent. So as we mature, I don't like to say age, but we mature like wine. Unfortunately, some of our cells don't act normally. They kind of go rogue. The machinery breaks down, right? The cells in your gut usually replace itself every 5 to 7 days or so. But if it doesn't replace itself, then it starts growing, right? Then you end up with something called a polyp. And then as that polyp continues to grow, there's a chance that it can become cancerous, right? And what is cancer? Cancer is, how do you say, is a unfortunately greedy element in your body because it starts siphoning nutrition and such that your body needs. That's why when you have cancer, it's not unusual where patients become thinner than normal because they're eating all of this, but the cancer and all that other stuff is unfortunately siphoning all the nutrients. But why do I present this slide itself? As you can see, a polyp becomes abnormal and it takes time to grow before it becomes cancer, right? As you see on the bottom, it can range the extent from where you see it when it's small to when it becomes cancer. It can take up to 20 years. So there's a reason why the screening recommendations are what they are, because they've looked at all of these, right? They've looked at polyps, how frequently how quickly they become cancer, right? So when you hit the age of 45, because now it's no longer 50, and I'll talk about the reason why. And when you hit the age of 45, even without a family history of colon cancer, it's recommended that you get a colonoscopy. We call you average risk. No family history, but you still recommended to get a colonoscopy. So you get your colonoscopy at the age of 45. If there's nothing, it's 10 years out before your next colonoscopy, right? So there's a reason why. These things take time. So we have time to find them, take them out before they become an issue. So colorectal cancer is the third most common cancer in the world, actually. And we say sporadic. Colorectal cases are sporadic. What does that mean? It actually develops some abnormal mutation in your gene. You don't necessarily have to have it inherited from family members. If you do have a family history of colon cancer, yes, you should be screened earlier, right? Usually we say if you have a family member who has colon cancer and hasn't hit the age of, you haven't hit the age to screen, then it's usually 10 years before the age of diagnosis of your relative, right? So if they had cancer at the age of 50, your mother did, then you yourself would get screening at the age of 40, all right? So the incidence, unfortunately, is getting increasing per year, and it's diagnosed in younger individuals. And it is the most common cause of female cancers, deaths, followed by lung and breast. And the incidence in populations of 65 of mortality, death, is higher in women than men. And why is that? So the reason why is oftentimes women get right-sided colon cancers more so than men. Men get on the left side. And the difference is not only due to genetics, but also the signs and symptoms when they arise is more vague. It takes longer. And one of the reasons why is because on the right side, the anatomy, things can stretch. Not only is the genetics of it, it's a little bit more aggressive, but also it stretches. And the likelihood of you seeing blood in your stools, which is one of the indications for colonoscopies, are less, because as the blood goes through, it's processed and you don't notice it. Versus if it's on the left side and it's near your rectum, you're gonna see the blood, right? So not only it stretches, it takes time to grow. It can grow larger before symptoms can arise, be seen. All right, and then this is it's a colorectal cancer. It's a combination of genetics, lifestyle, and dietary habits. It's what you eat, what you do. The small lettering on the bottom is just specific changes in the type of DNA mutations and such in right side colon cancer versus left side colon cancer, male and female. So risk factors, right? We talked about first do relatives, your mother, your children, but also it's been emphasized, diet. A lot of what we about our health is through the diet and environment, right? So I take care of diverticulitis as well. And what is diverticulitis? Oftentimes it's like little hernias in your colon. And those little hernias in your colon can get inflamed. But to get diverticulitis, you have to have diverticulosis. The percent of individuals in the US that have diverticulosis is 40% or more. When you go to foreign countries that eat a high fiber diet, what do you think the percentage of diverticulosis is in those foreign countries? It's actually 0.2%. And when those individuals go to the US, migrate to the US, what do you think their percentage increases to? 40%. So we know diet, and we've been emphasizing, is important in our health, right? So, and now they have this saying, maybe they say you only live once, right? So, and we know to live a good life, you need health. The richest individual can't enjoy their life if they don't have health. So, we say try to live an active life, try to cut down on alcohol and tobacco. So tobacco can increase your risk of getting colon polyps and colon cancer by 10 times the average risk individual. So it's not unusual that when you smoke and you come into the colonoscopy suite, I will find a colon polyp or so, all right? So then we talk about, the other comorbidities, the diseases that come with, I guess, an unhealthy lifestyle, right? We talk about diabetes. Type 2 diabetes is one of the number one diseases in the US, and that's usually brought on by obesity and such. Then we have inflammatory bowel disease. Then we talk about environment, again, diet and activities. So the clinical presentation, 3 ways. The one that has less likely of finding, so we want colonoscopies to prevent cancer, but also to catch it if we do see it. Because I'll show you a slide, your survival is much higher. So they either present with, if you haven't had a recent colonoscopy, like blood in stool, constipation, abdominal pain. You get lab work and your blood level is low for some reason, but no one can find out why. You think, the bleeding is from hemorrhoids, but sometimes it's not. And then you're eating, but you're not gaining weight. So then there's asymptomatic individuals who go for a colonoscopy, and then we find it. Those have better outcomes. Then, of course, you definitely don't want to be the ones that are coming into the ED that, you think you've had constipation, abdominal pain, you've tried all the laxative, Colace, and nothing's coming out. Then that's usually when you're at that stage, then the cancer is pretty advanced. What does that mean? It isn't contained in the colon anymore. So they've done studies, 5-year survival rates. So localized, regional, distant. So localized is when it's just in the colon. We can cut it out. You have a great chance of surviving, living a long life. Versus if it's spread outside the colon, then it decreases. And when it spreads to other organs, it decreases even further. So prevention and early detection is what you want. So screening, as I said, they decrease the age of screening just because there are younger individuals being diagnosed with colon cancer. When they're found, usually they're advanced because you don't think you're so young, you have all this health, and then why would you get colon cancer? But it's not unusual, it's rare, but we've had very young people with colon cancer. So we talked about colonoscopy prevention, right? It's the only method to prevent colon cancer and also to catch it early. It's actually, if you talk to anyone who's had colonoscopies here, do you guys remember it? Not many people do. They usually say, when I see them after the colonoscopy, they're like, when are we gonna have it done? And I was like, it's done. It's usually 10 to 15 minutes, right? You're completely knocked out. You get the good juice, the propofol. And we go in, we see what we see, and then we tell you, hopefully you don't have anything. Then in 7 to 10 years, you repeat a colonoscopy. And then you can eat whatever you want afterwards. There's usually no restrictions. Unless you're on blood thinners, then you might have to hold off on that for a couple of days. But it's a scope that we put in. If we see something, we try to take it out. So, and a clean colon is necessary. I won't ask for who had to have a repeat colonoscopy shortly. And that's usually if you don't have a clean colon. If you can see, if that was covered with stool, we can't see a lot of things. So if we can't say we looked at your colon well, if you have stool everywhere. So it's very essential to have a to have a good clean bowel prep, follow the instructions, don't cheat, don't eat a meal. I only ate a breakfast the day before, It stays in your colon, believe it or not. I've had, corn and all this other stuff. They say, I ate corn 4 days ago. I'm like, we see it because it stays in there. All right. So coming to the point of the talk, which is don't sweat the prep. So as you can see, there's a huge variety. This is not even all of it, right? And the reason why is no one likes the colonoscopy prep. That's like the worst part of getting a colonoscopy. And, who wants to sit in the toilet all day? But in the grand scheme of things, it's like 1 day out of like 10 years, right? To prevent something that's pretty deadly. So I think it's worthwhile. So as you can see, different type of preps. The percentage next to each one is actually a survey they took on individuals who had colonoscopies and which one they prefer. And I have a lot of patients said, don't they have something different now? Don't they have like pills? Yes, they do. But there's like, you have to take like 24 to 40 of them. But if that's your, that's what you like, that's how you roll, then we accommodate for that, right? And so usually these bowel preps contain the same thing. If you look specifically, a lot of them have this PEG, which is just polyethylene glycol, or like sodium phosphate. Those are the two varieties, and some even have both. And usually the PEG, polyethylene glycol, doesn't hurt the mucosa. It's actually very gentle. The only thing is it's a huge volume, right? Not only you're drinking a liter or two, but you're also encouraged to drink a lot of water to flush it out. And usually for the polyethylene glycol, it's very safe on the colon, and also it doesn't distort your, we call them the electrolytes. And so it's good for individuals with heart, kidney, lung issues. And the other ones you can take, right? You just ask each provider actually have their own prep that they like. But we do try to accommodate for you because we do believe in the colonoscopy. I do colon cancer resections, but I'll prefer not to, right? So I took this from the University of Chicago, how to make the bowel prep easier. So you can talk to your provider, you know what you like. You can drink it, or you can take a pill. So ask them for it. And then try to make it, usually we say clear liquids, try to make it easier to drink. We say Gatorade, but some individuals say they don't like all the sugar, or they don't like the sugar-free drink, then use like Pedialyte or something like that. And then you can flavor your water, as long as it's clear, it's not red, green, or blue, you get distinct instructions. And you can drink it with a chaser, to leave a better palate in your mouth, with apple juice or grape juice, or refrigerate the drink. You can even put ice in your drink, right? With Miralax, it's like tasteless. I've taken it, so I know it's like absolutely tasteless. And if you get nauseated, if you know you get nauseated, you can ask for anti-nausea medications. Field pills can be given to you just so that you can complete the prep. Use a straw. They say it goes down faster. It contains the taste. And then usually most providers split the dosing, so you don't take everything in one sitting, because that's kind of rough. But they either split it the day before or like the night before and the morning of. And of course, clear your schedules. I've had patients who run errands. I don't know why. But why would you run errands when you know you're gonna be having diarrhea all day? I don't understand. But and then stay near a bathroom. And then a lot of patients will say, I have hemorrhoids. Are they going to get inflamed? Yes, they will. They will get inflamed, so that's normal. You can apply creams, do what you can for prevention, all right? And number one, I have patients who stay hydrated. I have a lot of patients come in and they're dry. And we say, you can drink, we don't want you dehydrated, because you can drink all the prep, but if you don't drink the water that's instructed to drink along with it, it doesn't wash it out. And again, you don't want to repeat this process anytime soon. All right, and then of course, focus on the goal. I like this advertisement, because what are you trying to do? Prevent a deadly disease, because it is preventable and such. So in conclusion, colorectal cancer exists but can be prevented. Try to decrease risk factors with lifestyle, diet, and exercise. Early screening is the best. And there are multiple types of bowel preps. Choose your flavor, or talk to your provider before choosing one. And then methods of making it easier to take. And what we've been re-emphasizing, colonoscopy prevents colon cancer. That's about it. All right, thank you.
At this time, I'd like to welcome Dr. Isabel Prieto and Maya to the stage. Maya is a certified physician assistant working in our colon and rectal surgery office at Advent Health, Carrollwood. She earned a Bachelor's of Science from Florida Atlantic University, then received her master's in physician assistant degree from South Florida. Maya's clinical interests are outpatient treatment of anorectal disorders, including hemorrhoids, perianal infections, and fecal incontinence. Dr. Prieto is a fellowship-trained urogynecologist who treats complex pelvic floor disorders using both non-surgical and surgical options, including vaginal, laparoscopic, and Da Vinci robotic pelvic reconstructive procedures. She's fluent in both English and Spanish and treats adult and geriatric patients. Dr. Prieto has always been inspired to help other women understand what is happening in their bodies throughout their lives. She dedicates time to get to know her patients so she can provide personalized, comprehensive care for a happier, healthier life. In her free time, Dr. Prieto enjoys traveling and her husband and daughter, the beautiful Florida beaches, and living a healthy lifestyle. Very good. Maya and Dr. Prieto are here today to answer frequently asked questions regarding fecal and urinary incontinence and offer treatment options for women to gain control of their health. So I will begin the questions here. Let's see. Dr. Prieto, first question is for you. I feel like constantly having to pee. Sometimes I'll go to the bathroom only to feel like I have to go again 5 minutes later. If I don't make it to the bathroom in time, I leak. Is this common? It's one of the questions.
Yes, absolutely. It's extremely common. Thank you so much for having me here today. I'm really, really appreciative. I see a lot of... I'm very passionate about speaking about these topics. I see a lot of my own patients here, so it's really exciting to get to educate you all more. This is extremely common. This is a conglomeration of symptoms that includes urgency of urination, frequency, going to the bathroom often, and then feeling like you just have that gotta go feeling where you just can't make it to the bathroom. You may leak before you make it there. That's something we call overactive bladder. And it's very, very common. Generally, what I say to my patients is about 1 in 5 women before the age of 80 in the US will have some type of pelvic floor disorder and seek treatment for it. Believe it or not, after the age of 20, about 25% of women will develop some type of urinary incontinence. So it is much more common than anyone thinks. I think we try to encourage people to speak about it because there are a lot of treatments. Everything we do is from conservative to surgical treatment options. I don't know if we'll have time to hopefully get into a little bit of the nitty-gritty today, but a lot of things start with bladder retraining techniques, dietary modifications, pelvic therapies that re-strengthen the pelvic floor, and we retrain, I call it mind over bladder, kind of getting to know when you have to go. A lot of us hold our urine and we have careers like we call it the nurse's bladder or the teacher's bladder, where you're used to holding your urine and you don't go to the restroom, and that can lead to problems in the future. So that bladder retraining is super important. There are medications that we can use. Medications basically calm down the bladder muscle, so we don't have to feel like we have to go all the time. We can hold the urine and make it to the bathroom in time. And then there's what we call third-line therapies. There's a few different third-line therapies that we use for overactive bladder. In a nutshell, there's essentially 3 major ones. So we do what's called percutaneous tibial neurostimulation. It's a fancy way of saying we put a little ankle acupuncture needle and we stimulate a nerve ending that goes from the brain to the bladder. And that kind of calms down that bladder muscle. That's the least invasive of the treatments that we do for the third-line therapies. There's really no risk to you. It's done in the office. It takes about 30 minutes, and you come to the office weekly for about 12 weeks. There's also Botox injections that we can do into the bladder. Believe it or not, I say it's kind of like, takes away those wrinkles, takes away the wrinkles in the bladder, and it calms down that bladder muscle so you don't feel like you have to go as much. In general, all the procedures we do, there's small risks. As far as Botox, it's a very safe procedure, very effective procedure. Small risk of urinary tract infections, or that the bladder doesn't empty for a small amount of time. But again, small risks. And the last but not least, it's something called a sacral neuromodulator. And so sacral neuromodulators are basically like little pacemakers for the bladder. we place a little hair-like wire in the lower back, and we implant a very small battery in the butt cheek. And that constantly depolarizes or sends signals to that nerve that goes both to the bladder and to the anal sphincter, so it is also approved for fecal incontinence. Sorry, Maya, I'm rubbing you're fired today. But basically, it calms down both of those. It re-strengthens that anal sphincter, and it calms down that bladder muscle, so it's approved for overactive bladder, urgency urinary incontinence, and fecal incontinence, as well as non-obstructive urinary retention. So that's my nutshell.
Very good. No, very detailed, and we need that. So Maya, I know that there are women in the room who are too shy to, or embarrassed, to ask. So tell us, what is fecal incontinence, and is it common?
So fecal incontinence is often related, or patients say, is fecal smearing or fecal leakage. And I think it's a little more embarrassing to talk about than urinary incontinence, just because I feel like as women we're told it's normal to leak. I'm pregnant, obviously, and I've been asked multiple times, oh, do you have that yet where you sneeze and you pee? But no one's asked me like, hey, how are your hemorrhoids? How are your bowel movements? No one wants to talk about that. So fecal incontinence is a lot more common than we realize. They say about up to 18% of women can have fecal incontinence, but it's just nothing we want to talk about. Even when you see your providers, who wants to say, hey, I'm pooping my pants in the middle of the night, or I can't make it to the bathroom in time, because it's really embarrassing, especially when you're talking about poop, because it smells, you have to change, pee's a little easier to hide, it's not as evident. So it is very common, but I feel like a lot of women don't seek treatment for it just because they're scared to speak up about it. And unfortunately, they should, because there's great treatments out there and patients can do really well with them and live a good, happy, healthy life without any incontinence issues. So.
Not waiting so long to finally disclose what their problems are. Dr. Prieto, next question. Thank you, Maya. I get up at night a lot to use the restroom. If I sleep through the night, sometimes I wake up wet. So I wear a thick pad to bed. I just want to get some rest. Why is this happening?
Great question. The reason why it's happening is there's a lot of different reasons, right? So this is something called nocturia, or nighttime voiding. There are, as far as risk factors for developing urgency, frequency of leakage, overactive bladder, and nocturia, the number one cause is age and being a female. So sorry, ladies, but it is very, very, very common. Unfortunately, as we age, these disorders start to become more common. There are other risk factors, such as genetics. It plays a role. A lot of times we didn't speak to our grandmothers or our aunts about this, but it's something that they unfortunately led with as well. Also, weight is a big one. Unfortunately, as we get older and we start to gain weight as females, it's very, very common. We start to carry our weight, and that weight does unfortunately affect the pelvic floor function. Things like smoking. Smoking weakens our tissues. It robs oxygen, is what I say, essentially, from the most delicate tissues that we have, including the urethra, the bladder, the vagina. So that's a big risk factor for developing incontinence. There's many other reasons, like medical conditions, such as diabetes, for example. Diabetes can affect nerves, and the bladder, I say, is an end organ. So those nerves start to become affected, especially if that diabetes isn't well controlled. One of the reasons that I always kind of screen for in my office is something called obstructive sleep apnea. Mm-hmm. Women don't realize, I always ask, do you snore? Do you have daytime sleepiness? Because it is a big risk factor for nocturia and urgency and frequency of urine. Women that have undiagnosed obstructive sleep apnea and don't wear what's called a CPAP machine, which is the machine that helps push oxygen into the lungs, actually start to release what's called an ADH, antidiuretic hormone. It's a natural diuretic hormone in your brain, and it acts like as if you were taking a water pill. So it makes you go to the restroom more often. And so studies have shown that wearing a CPAP machine can actually decrease nighttime voiding episodes by as much as 2 to 3 per night. So that's something that I'm big on screening for in my patients when they first come into the office. But in short, I'll make it a little bit more short and sweet. The treatments for nocturia are quite similar to the treatments for overactive bladder, right? The goal is to allow you to get a really good rest throughout the night, get up in the morning, have a nice, solid void in the morning, and go about your day. So they do cross over in those treatments.
Thank you so much. Maya, now that we know a bit about what it is, can you tell us who is at risk for fecal incontinence and how is it diagnosed?
Okay. So again, women, which is why we're talking about it today. Women are twice as likely to have fecal incontinence, but I think in reality, the majority of patients we see in clinic are women who have fecal incontinence. And the reason is we carry babies, we birth them. During birth, you can injure your anal sphincter muscles. Age, your pelvic floor gets more lax. We are also don't have the time as men to sit on the bathroom for 20 minutes or go when we want to because we're running after toddlers, or we're at the grocery store and you just hold it all in and hope you can find a bathroom in time. And can you repeat the second question?
How is it diagnosed?
So it's really diagnosed in clinic. Patients come in and when they finally get to the point where they're not leaving their home or they can't go on their trips or their vacations with their families, and they finally get to the point of enough is enough, and they speak up about it. We actually use a Wexner fecal incontinence score, which is just a couple of very simple questions to determine how severe is your fecal incontinence. Is it mild? Is it moderate? Is it severe? And then we can discuss treatment options in regards to where you kind of fall on that scale and how aggressive you want to be in treating it.
Very good, thank you. Our next question says, I used to be able to go running and exercise, but now every time I try, I leak. I want to be active again. What can I do to fix this? Dr. Prieto, perhaps you can shine a light on some of the treatment options available to women who experience similar symptoms.
Yeah, absolutely. So this is an example of a leakage called stress urinary incontinence. So the bladder has two parts. If you've been to my clinic, you see my hand a lot. So the bladder muscle holds the urine. The urethra is the tube that you pee out of. So when you cough, laugh, and sneeze, it should really kind of kink off like a water hose, right? When there's not that strength isn't no longer there and those urethral ligaments are kind of weak, unfortunately, we leak, right? The mechanism happens with stress, anything that puts pressure on the bladder. That's why it's called stress incontinence. The treatment options, again, start from conservative to surgical. One of the conservative options is pelvic floor therapy. So generally what I say is we refer you to a pelvic floor therapist. They're women who specialize in the pelvic floor. They do internal and external examinations. Stress incontinence can have a lot to do with core as well. So they do core evaluations, vaginal evaluations. They use techniques such as biofeedback, which is basically like using like a little video game almost to show you when you're squeezing appropriately, when you're activating those muscles so you can get some feedback and actually do those Kegels appropriately. Most women, what I say is 90% of patients that come into my office and try to do a Kegel are recruiting their butt muscles most of the time. And so we have to really focus and hone in on knowing which muscles we're activating. There's also non-surgical treatment options. There's two. There are actually some incontinence tampon kits that you can get over the counter at any pharmacy. And so you can actually fit yourself. They are basically tampons that sit underneath the bladder neck and they help kink off that urethra. Especially as women become older, they can be a little bit uncomfortable. It is a tampon, it's dry, especially if we're already dry vaginally. Those can be a little bit uncomfortable, but I do have some young women who are just active and they use those as they're running or whatnot. In the similar class is something called a pessary. A pessary is a ring-shaped device that was actually developed for what's called pelvic organ prolapse or vaginal prolapse, the vaginal walls coming down. We developed a pessary that has a little knob. It sits beneath that urethra, so when you cough, laugh, and sneeze, it helps decrease that leakage. Those pessaries are devices that you can either take in and out yourself, or we can maintain them in the office, checking them about every 3 months. And then there are surgical treatment options. So the surgical treatment options, there's a variety. Starting from what we used to do quite a long time ago that are basically native tissue slings, right? Autologous rectus fascial slings where we use actually your own tissues to create a sling and place it beneath that urethra. We do still do this in certain cases, but unfortunately it's a little bit more of a morbid procedure. It's reserved for women that have failed other therapies. We also use what's called mid-urethral slings. Mid-urethral slings are made of polypropylene mesh. They are the FDA gold standard for stress urinary incontinence, and they've been around for a very, very long time. Mesh is a really scary word in my world, and I get that question every single day. And generally what I say is the meshes that we use currently are meshes that have been well proven for a very, very long time. Now, meshes, yes, always have a very, very small risk associated to them, but in general, women do really, really well. We can usually look at the studies and say about an 85% to 90% efficacy, meaning that that's how well it helps the stress urinary incontinence improve. And then we also use what's called bulking agents. There are a lot of different types of bulking agents. How I explain it is basically it's like fillers for the face, it's fillers for the urethra. So we do it cystoscopically. It doesn't require any incisions. We basically, through a little camera into the bladder, we inject the urethra and we cushion the urethra from within. So there's no incisions. You don't see anything out on the exterior. As far as bulking goes, we have the newest agent on the market called Bulkamid. Bulkamid is 98% water and 2% polyacrylamide. It's basically a material that can eventually be degraded by your body, right? It's not as permanent as mesh, but it works really, really well. Up to about 7 to 10 years is what the data shows now. And low risk of it causing any harm to you. Really, the only risk of Bulkamid is a UTI, which is a risk for every single procedure I do. Unfortunately, we're UTI bladder infection. We're operating around the bladder, so that's an innate risk, but again, small risk. And it's a good treatment option for either women that don't have downtime to recover from a sling, because the next day you can go back to work. Or women that in general just aren't candidates for slings. So there are definitely treatment options out there. I definitely encourage everyone to reach out to your doctor and just discuss those treatment options. And if not, come on over and see me.
Very good. Because of time constraints, I'm going to do these last two kind of like dual. Maya, all the women in my, this one actually, how is fecal incontinence treated? That's the first part. And then for Dr. Prieto, and then you'll just go run right after the other. All the women in my family have had problems with leakage of urine. What can I do to prevent this from happening to my daughter? So, generational.
So treatment for fecal incontinence, it can start with being as simple as bulking up your stool, right? If you have watery or very loose bowel movements, it's easier for things to sneak out. So things like fiber intake, some women will take Imodium, which is an antidiarrheal medication just to make things thicker. A lot of them will do that before a big event, before getting on a plane, just because they feel more comfortable that they won't have an accident. And that's the very simple beginning of treatment. There is an injection, which is a bulking agent. It's called Solesta. We don't do it in the office very often because it's gotten really hard to get from insurance purposes, and a lot of women pay out of pocket for it. So it becomes very expensive. It only works about 60% of the time, and at 36 months, most women have achieved where they can achieve and even start to have recurrence of symptoms. There's another, we can do anal sphincter surgery, which again, we don't do very often because very often it's a hard surgery to recover from, it's not easy, and with time, your symptoms will recover. Our most commonly used treatment is the sacral nerve stimulator that is also used for urinary incontinence. So if you have both, it's nice because it treats both options. It's a two procedure thing where we do one in the office. So you come into the office and we put in actual trial leads and you wear an external battery for a couple of days. And it's nice because before you get this implant put into your body for life, you know, do I actually have improvement with this? Does it actually work? Before we go and take you to surgery and put a battery into your buttock for probably life. After 5 days, you come back to the office, we remove those leads, and we talk about, did it work or did it not work? If it worked, we book your surgery. It's really simple. Everyone goes home the same day. And 80% of women will have a significant improvement in fecal incontinence. Does that mean never have an episode ever again? No. But if you have 10 a week, you might have 2 a week. And to me, that's a lot different. If I'm going 10 times a week without knowing, and then all of a sudden I'm going only twice a week, I feel a lot more comfortable about going about my day. And that is usually our mainstay treatment in the clinic for fecal incontinence.
Very good. Yeah, I agree with that. As far as preventing this, talking to your daughters or your nieces, really it has a lot to do with just being conscious of your bladder habits from the beginning. We a lot of times learn to kind of push to void, especially as kids, because that's how you develop the continence mechanism, or actually not peeing your pants as you're potty training. My daughter laughs at me because she's 4, and I tell her, "Are you listening to your bladder?" She's like, "Mommy, I listened to my bladder today." I'm like, "Good job." So I tell her, I'm like, "Don't push to pee. Let your bladder relax and do the work." Sometimes even kind of just knowing, what to do and what not to do as far as pelvic floor exercises, things like that. There's exercises like heavy lifting and CrossFit, unfortunately, really strenuous exercises that can put a ton of pressure on our pelvic floor as we're young and we don't realize it. So definitely talking to your kids and informing them of things that can, be modified. And then, just that learning basically how to Kegel, Kegels can help a lot from the beginning. But also optimizing bowel function, that's a big one, because women who have urinary dysfunction often have what's called constipation or fecal dysfunction. And so women that have a long-standing history of constipation unfortunately have problems with urgency, frequency, and bladder leakage as well. So really staying conscious of trying to find the best dietary modifications and the best, supplements that you can use to keep that smooth move, having a nice soft bowel movement daily where you're not pushing, can really help prevent problems in the future.
Very good. Thank you so much, ladies, and thank you for answering questions that most of the time we're afraid to ask. But open up, ladies. There are resources, so thank you so much. Yeah, careful there. Okay, next I have the pleasure of introducing Dr. Carol Cox. And I work with her very closely too. Dr. Cox is board certified in obstetrics and gynecology and brings over 20 years of experience in advanced gynecological care to Tampa. She has practiced the full spectrum of OBGYN, delivering babies and performing surgeries, but now focuses on office gynecology, managing everything from contraception to menopause. She is a strong believer in empowering women through education. Without further ado, welcome Dr. Cox.
Thank you very much, Teresa. It is a pleasure to be here. I think that it's great where I've been scheduled in the program, not because of what you would think of being towards the end and talking about menopause, but because what we're going to talk about here ties together everything that has gone on. I was busting at the seams during all the presentations, thinking to myself about how that's just like what I like to tell my patients. And that's it. When I see a patient who is around perimenopause or menopause, and just their well woman, we're talking about everything that was talked about already today. And also learning about it, being here today, is really the most important thing that you can do for yourself in being able to manage any issues that are going to arise for you. So menopause is not a disease, although it's a diagnosis that we use when I see somebody for a visit related to this. It's not a disease, it's a transition. It is a natural thing that women will go through as part of the reproductive cycle. And the question is, how would you describe menopause when talking to someone in casual conversation? We have a lot of words that people will use to describe it, and some of them positive, some of them negative, some of them matter of fact. Ovarian retirement, that's what it is, right? It's just they're done. Reverse puberty, that's also pretty accurate. I even use that sometimes with my patients to tell them, puberty might have been rough for you, and you might experience some similar things now. There might be a negative connotation to it, something like the super soaker event. Or you might be somebody who is going to take the positive. I'm experiencing power surges. I'm going through my second spring. I think that no matter what, it's important to realize that you have your own approach to it, and it's going to need to be individualized to your goals, and that you should be proactive in getting those addressed with the provider that's going to help you through this. So I do have a little bit of quiz here, so if you want to go ahead and hook up to that, we're going to do a few quiz questions. And while you're getting that, I'm going to throw one thing in that I did think of that I really have to say based on the last couple presentations, talking about a cancer that is preventable. Cervical cancer should be 100% preventable if everyone gets vaccinated for HPV. So most people in this room are probably around the age that we missed that because the HPV vaccine's not been out for that long. The younger women in your life, it's recommended up to age 45. And anyone who is within that time frame and wants to be able to 100% prevent getting cervical cancer needs to get the HPV vaccine. The other thing is talking about how to talk to our daughters. That's where this is coming in, is that all of this education that you get here can be magnified by sharing it with other women in your life and being a source of good information for them. Because in menopause, I spend at least half of my time with patients dispelling bad information that they get from people who want to sell things that are going to help you through menopause and are giving misinformation. And that's some of what we're going to address with these questions too. So here's our first question. How long does menopause last? 1 day, 1 year, 10 years, forever. Are we active? There we go. Oh, I have to look up here to see it. Okay. All right. So I'm the type of person who's going to give you the trick question. So it's actually 1 day, menopause. Okay, here it is. Where's my pointer? All right, this is menopause, that one right there. So the definition of menopause is it has been 1 year since your last period. That could be tricky, right? Because if you're on hormones for birth control, maybe you don't get a period, or if you had a hysterectomy. But that's the actual definition of menopause. It is the day that is 1 year from when you had your last period. Everything before that is premenopause. Everything after that is postmenopause. So let's go through a little bit more vocabulary here. The average age of menopause is 51. Typically, it's somewhere in the 45 to 55 year range, but it can still be normal anywhere from 40 to 60. And if you, that ovarian retirement that I referred to earlier is literally what's happening. We are born with all the eggs we're ever going to have, and in puberty, the ovaries start to rev up, they start to ovulate. We get some of the variation in hormones that you see here. This is estrogen and progesterone over the course of the lifetime, just sort of roughly where their levels are. And so it can be rocky at first with irregular cycles and symptoms up and down in puberty, and then we have our fertile years. And we're showing here that the hormone levels are highest during our fertile years, but of course they're also fluctuating with the cycles. And then when you get into perimenopause and the ovaries are not ovulating consistently, we start to get irregularity in the hormones again. And postmenopause is at the lowest levels, lifetime. In fact, it's kind of right back where you were before the ovaries even started. There are some things that actually are common before puberty and also can occur in menopause. So there's a couple other terms. Premature would be before the age of 40. Induced menopause would be if someone had a medical condition where they would benefit from shutting down their ovaries. And that could be something that happens through chemotherapy or hormone treatments. And then there's surgical menopause. If you had a hysterectomy and had your ovaries removed, or just had to have the ovaries removed for some reason. And typically people who have that will experience more aggressive symptoms because it was such an abrupt change that they had in their hormones. So This is where most of the problems arise, is perimenopause. That this is where, because of the fluctuations in the hormones, women are experiencing the most symptoms. So this is kind of where we're going to focus in. And so do we need to check hormone levels to know you're in perimenopause or postmenopause? In order to know where you are, we need to check some levels of hormones. True or false? Okay, I told you I'm the not nice trick question person. So this is false. And the reason it's here is because this is one of those misconceptions that women think that they think because there are many places that will market to come in and get your hormones tested, because then you can get some specialized treatment for your hormones. So we're going to go through why that is not necessarily the best way to do things. And the reason is that the personalization is not about a level of blood work on a lab. It's about you as a person living your life and how the symptoms that you're experiencing affect your quality of life, okay? My estrogen level and your estrogen level can be exactly the same, and we experience it totally differently. So it's not about a number in a lab. And the other reason is that there can be natural fluctuations. So if you look at the menstrual cycle, estrogen and progesterone, which are in the middle here, are fluctuating all throughout the cycle. And so when someone's in perimenopause and they are starting to have inconsistent ovulation and their hormone levels are fluctuating, they'll get irregular cycles, literally their hormones are all over the place, up and down. So my question usually when someone is, asking about hormone levels is, which day of the month shall we check them? Because they could be at one level one day and they could be another level completely a few days later. I know your hormones are an issue. It is the fact that they're fluctuating so much that's the issue, not an actual level. And so the body parts that are affected are all the ones in which estrogen is active, and this is our whole list that correlates to the symptoms that you can experience. The one level that could be helpful is called follicle-stimulating hormone, FSH. This is a hormone that comes from the brain, and its job is to stimulate ovulation. So when your ovaries are running out of eggs and no longer ovulating, it's going to go up because it's going to be trying to tell the ovaries to ovulate, and it's not getting a response, so it goes up and up. So we see high FSH levels in menopause, and that could be helpful for people who have had a hysterectomy and they can't rely upon looking at their menstrual cycle to see what's happening with regard to menopause, or under circumstances where you want to know if somebody needs contraception anymore. If they're still ovulating. So that's the one level that could be helpful. And it's also helpful to do labs, to do blood work to look for other causes, because thyroid disorders cross over with many perimenopausal symptoms and menopausal symptoms. So we want to rule out that there's not something else that's causing them, but it's not a matter of looking at estrogen and progesterone. All right, so hot flashes happen because of decreased estrogen in the uterus, the heart and blood vessels, brain, skin, and hair. All right. So I think that is correct. It is the brain, and I think that people might be hearing some more about this because there's some new stuff that's coming out with new treatments that's really providing good education about this. And this is by far the main symptom that occurs in most women experiencing perimenopause and menopause, is the hot flashes, in which decreased estrogen in the hypothalamus is confusing the thermoregulatory mechanism and making there be a sensation of excess heat, which causes dilation of blood vessels to try to bring the heat down with flushing and sweating. And it can really vary in severity. There's some ethnic components. Some women, Black women, tend to have more severe and prolonged hot flashes, and whereas Asian women tend to have less, but it's very individual, and there can be individual triggers, timing of when somebody has them. And when you have hot flashes that occur multiple times a night and are disturbing your sleep, that is really problematic for your entire quality of life and has a downstream effect on a lot of these other symptoms that we see in terms of memory problems, mood problems, irritability, headaches, and that adds stress, which then makes it hard to have all of the other healthy habits that we've been talking about during the day today. So this graphic kind of shows you that over the course of that transition, there tend to be more symptoms that are early on around perimenopause, and that's the ones that we were just talking about, and those do tend to get better over time, but it can take years. So this is why it really should not be the approach to say, like, I'm just going to try to, wait it out. If it's really affecting quality of life, then it deserves to be addressed. All right, so hormone replacement therapy can improve all the symptoms of menopause. True or false? Right. Yeah, that's pretty obvious. And again, you've been hearing lots in the talks today about everything that you need to do for all of these things, for your bones, for weight. As far as hormone replacement therapy, it can be very effective for hot flashes, and it can have its own effect on mood. Or it could be that by improving hot flashes, it improves mood. It also does protect against bone loss and has some reduction in colon cancer risk. If you have a uterus, you have to take progestin with estrogen. Estrogen is what helps relieve the symptoms, but you have to have a progestin also if you haven't had a hysterectomy. And you can use hormones in pills, patches, gels, sprays, rings. There's all sorts of options, and this should be very individualized to the person. There's also estrogen that can be used locally in the vagina, because that is a big component of later menopausal symptoms, is vaginal dryness, discomfort with sexual activity, and then urinary effects. And so using estrogen in the vagina, either in combination with or instead of systemic, is the way to address that, is the best way to address that. And we're going to talk about alternatives to these things in a minute. And that can be with creams, suppositories, tablets, or rings. I'm going to go back and re-emphasize this, because you can now buy over-the-counter estrogen in what is equivalent to prescription strengths. And it's very disturbing to me to see this, because if you start just taking estrogen on your own and you don't know that you have to take a progestin, if you do that for years, you'll get uterine cancer. That's what estrogen does to the uterus in the absence of progesterone. The graphs that show what they do, it's a wonderfully designed system that works together to do what needs to happen for reproduction. But too much estrogen compared to progesterone will cause cancer of the uterus. So it's important that you have an appropriate type of progestin and that it is in adequate levels compared to the estrogen that you have. And that is why I cannot emphasize strongly enough FDA-approved regimens that have been tested and known to have this safety. Because I do have a quibble with Dr. Parker's slide from earlier that said that HRT causes uterine cancer. FDA-approved regimens of HRT do not cause uterine cancer, because they have this appropriate balance. But there are ways that you can not have that balance, and that is with going to compounded hormones. And we're gonna address that in a sec. And one other side thing on that, progesterone cannot be absorbed through the skin. So I see that too, people are getting it that way. So you can take HRT in many ways. You can take it in a cycle continuously. You can do patches, orally. And the term bioidentical is very misused. The vast majority of FDA-approved regimens for hormones are bioidentical. They come from natural sources. There are some synthetics, but mostly they are what is called bioidentical. They are not these compounded hormones that are made and really customized in small pharmacies, which also means that they're not as reliable what levels they actually have in them. Perimenopause is a little bit different in that if you're still ovulating and having some cycles, you might need something a little bit stronger, and low-dose oral contraceptives is really the most ideal for addressing symptoms in perimenopause with all those up and down fluctuations, that it can really smooth all of that over, and provides birth control because you don't know if you still are ovulating at that point, and you can still get pregnant as long as you're ovulating. Side effects are similar also to birth control and are like having menstrual period types of side effects. So vaginal bleeding and some of the other symptoms there. So as far as the risks, anytime you take estrogen, there is a cardiovascular risk associated with that. And the breast cancer risk, let me say this about it, that it is really very small, was highly overblown after the Women's Health Initiative. And this was something else that was mentioned before by Dr. Parker, that there is some risk there, but the Women's Health Initiative average age was 65. So those women already were at higher risk of breast cancer. And there has not been shown to be an increased risk of breast cancer in women who are younger who are using HRT. So that is why the target age is really, if you're gonna need to use some hormones, to start it right when you go through menopause and to use it initially as you go through that transition. And during that time frame, there has not been the same kind of risk. And the risk is only with combined estrogen and progesterone for women who have a uterus. It's not an increased risk if you are taking estrogen alone. That has never been shown, even in the Women's Health Initiative. So the people who really can't use any hormones are people who actually have breast cancer or have a very high risk, have cardiovascular disease, or have a history of uterine cancer. Unexplained bleeding is something that we often see in perimenopause, and so before starting somebody on hormones, I would check that out and see what's going on with it. And if you use a patch, it decreases these risks. And then I mentioned about compounded hormones, that I have real concerns, and I see patients who have side effects that are a result of misbalancing of the hormone levels there. So this brings up, do you need to have hormone levels to know if your treatment is effective? So this is the other major misconception. I don't need hormone levels. I need to know if your hot flashes are better. If your hot flashes are better, then it's the right thing for you. And are you having side effects? So this is what's recommended by the American College of OBGYN. You do not need to follow levels. You need to follow up on side effects and symptom relief. I'm running over, so I'm gonna go quickly here, but non-hormonal therapies, there are a lot of great alternatives. Customize. If you don't like the idea of hormones, then hormones is not for you. If it's gonna make you scared, then hormones is not for you. But there are a lot of other options that we have that can focus specifically on what are the symptoms. So that is the thing, is to show up and say, these are the things that bother me, these are my goals, what are my options, what are the risks, and decide for you what is gonna work. For the vulvovaginal, I also think it's really important to start thinking about how to care for that area as you age, and to be really proactive about the sort of things that you can do to prevent having very thin tissue that's going to be susceptible to infections later in life and cause a lot of irritation. And this is a list of the kind of things that we can do, is really start to be cautious about avoiding irritants in the vulvovaginal area and considering some local estrogen or hyaluronic acid, which it's so funny, Dr. Prieto is like, for the things for wrinkles, same thing. That's what I tell my patients. Use hyaluronic acid for wrinkles here, it's good there too. And vaginal estrogen has none of the cardiovascular or breast cancer risk. Vaginal estrogen is 100%, it is good to go. It is in the vagina. It is not causing any of those cardiovascular problems. Even women who have had breast cancer can use vaginal estrogen. So I focused all on the hot flashes and the vaginal health stuff because I'm a gynecologist. All these other things are the things that you already heard from all the other doctors today that all apply in menopause: how to reduce your cancer risk, keep your bones strong, help with your mood, and we didn't have a skin doctor, but that's another important one. Sex drive, we could talk all day about that. And I know that that's an important concern. I am by no means minimizing that. but that you need to talk individually with a doctor about and really hear how it's a multifactorial issue that needs to be addressed in whatever ways are going to work for you. All right, so last one. What's the best time to use hormones or other medical interventions for your menopausal symptoms? Absolutely. As soon as they are reducing your quality of life, and preferably within 10 years. So that's why it's A and B, because of what I said about how you have less risks. Cardiovascular risks and breast cancer risk is higher if you're using hormones in your 60s. 50 to 60 is the ideal time to use hormone replacement therapy, and then see if you can come off of it. And then this is just my conclusion of reframing how we think about menopause, to realize that each woman is unique. We have complicated physiology, and we really deserve an individual approach to experiencing this transition. A lot of times we're bumping up against a culture of silence, of thinking that we shouldn't be talking about these things. And I wish for every one of you to have providers who allow things to be open enough that you can bring up any of these issues with them, and educate yourselves. And these are some resources where you can find good information about menopause. And that's it.
Thank you very much, Dr. Cox. A lot of benefit here. Well, last but certainly not least, we have Dr. Christine Yogesh. Dr. Yogesh is a vascular surgeon and is deeply committed to the care of all her patients and honored by the privilege to help them restore their whole health through expert surgical care. She spends extra time with each patient to ensure they are well informed and involved in their unique care plan. Today, she will be sharing the ugly truth on varicose veins. I welcome Dr. Yogesh.
Hello. Hi, I'm Dr. Yogesh. Thank you, Teresa, for that wonderful introduction. I'm a vascular surgeon at Advent Health Tampa. Nice to meet everyone. So today we're going to be talking about varicose veins, and my goal for this talk is it's pretty short. There's not a lot to really talk about when it comes to varicose veins, and I wanted to open it up at the end to questions, any questions you guys might have, okay? So we have someone who will come around with a mic afterwards, so if you have questions, just raise your hand and we'll get to you, okay? So what are varicose veins? That's a really common question. What are they? So it's a condition in which the veins can be enlarged and tortuous, which basically just means a fancy word for saying that they can be twisted. So I have a picture here on the next slide of some examples of varicose veins, and these are rather extreme examples, but this is what it can be. Typically we see it on the inner calf, inner thigh. There's a vein that runs along there. It's called the saphenous vein. It's usually the culprit. You can get venous insufficiency here. The veins can become enlarged that feed off of that vein, and this is what you can get. It can be this enlarged, tortuous, twisting varicosities coming off in that area. Commonly, it can also happen behind the knee. So what causes these? So these are caused by weak or damaged valves in the venous system. So the venous system basically is the system that brings deoxygenated blood back to your heart. The arterial system is what takes the blood from your heart and brings it to your organs, okay? So the way that the veins work is you have the blood flow coming from the feet, coming up the legs, and you have these valves that are supposed to close in order for the blood as it goes up to not be able to go back down, to keep moving up towards your heart. Over time, if these valves become damaged, as you can imagine, the blood can just sit there in the feet, in the ankles, in the legs. You can get swelling, engorgement of the veins, and that's eventually how you get varicosities. So this is just a fun little picture here that shows the weakening and that twisting appearance of the varicosities. So what are the risk factors for these? So age, over time, just advanced age is the most common risk factor. Your valves can become damaged with standing. The more that you stand, if you have a job where you stand a lot or you sit with your feet down, the blood gets pooled there. Gravity is not your friend in this situation. It's working against you, and that can cause the valves to become damaged. Gender, so it's more common in females. Pregnancy, your hormonal changes with pregnancy can definitely cause varicosities, obesity, family history, and any trauma to the vein system as well. So symptoms associated with varicose veins, you can have pain in your legs, heaviness, tiredness, cramping after standing for long periods of time. Swelling is a major problem. A lot of the times you'll have swelling, worse at the end of the day. They can improve after you've been able to elevate your legs at night. In extreme cases, the varicosities can actually have bleeding, and you can get skin changes, usually darkening of the skin near the ankles, and occasionally even wounds that have issues with healing. The treatment for these will start with the conservative therapy, which is compression. If you've seen me over at my booth today, I've been kind of telling everybody to wear compression. I wear compression every day. I'm wearing it right now with my taco socks. You can get compression and therapy, compression socks at Amazon. It's really important if you're standing or if you're sitting and you're keeping your legs down and not elevated, compression is your friend. Wear it every day. And then elevation is number 2. So at the end of the day, when you get home, you have swelling, put your feet up. Just help yourself because the gravity is not helping you. So put your feet up to kind of help that blood flow come back up to your heart to keep it from sitting down in your legs. Weight loss as well. And then the other treatments, the treatments that I can offer in my clinic would be ablation or microphlebectomy. So ablation is when I actually turn off that major vein that you have that kind of runs along the inner leg that varicosities tend to feed off of. We can get an ultrasound. If it shows that the valves in that vein are damaged, I can turn that vein off in the clinic for you and hopefully get rid of those varicose veins that are feeding off of there, okay? The other treatment, if that alone doesn't work or if it's not that vein that's feeding it, I can make little tiny incisions or little puncture sites and actually disrupt the varicosities, basically remove them, also in the clinic, and that's called a microphlebectomy. Another thing I just wanted to touch on, because this is also an area of common concern for women and for myself also, is spider veins. So what are spider veins? They're damaged blood vessels just beneath the skin surface. It's not limited to venous disease. It can sometimes be little damaged arterioles as well. It's not as well understood as to what causes these as varicose veins, but we do know what the risk factors are. And the risk factors are similar to varicose veins. So age, gender, pregnancy, obesity, family history, and trauma. The treatment for this, so it's similar, it's an injection, but it's not the same thing as closing off a major vein. It's these tiny, tiny little spider veins, and I can, again, do this in clinic. I inject a sclerosing agent into these small veins, and it shuts them off, okay? You can see the little picture of the diagram that I have up here. That's the sclerosing agent that goes into the little spider vein there. Over time, it causes the vein to completely sclerose. Your body reabsorbs the blood, and the vein just kind of fibroses. It goes away, and you don't see it over time. It takes about 4 to 6 weeks for it to completely disappear, but it's just with these little injections that we do in clinic. And here are some examples of varicose veins before and after treatment. This is before and after ablation treatment. You can see the varicose vein along the medial calf or the inner calf, which is a common place to have these because that's typically where that vein is. That's the common culprit that causes varicose veins. After we shut that vein off, you can see now the varicose veins went away. Over time, they're just not filling anymore, so they just kind of disappear. Similar situation here. Went to the back of behind the knee. Ablation therapy worked for this person, and spider veins before and after. Now, this is a good amount of spider veins, so this takes a couple treatments in the clinic to do. We don't tackle all of this at once because we don't want to cause any damage to the skin by giving you too much sclerosing agent to the skin, to one area at once. So this takes a couple treatments, and then again, 4 to 6 weeks afterwards, usually those spider veins will just kind of disappear. So what questions can I answer?
What are your thoughts on pentoxifylline?
So there's some data out there to suggest that that can help with venous insufficiency, and I do suggest it to my patients, actually. The data is limited, and it's still kind of in the works, but I think that it has been shown to help with venous insufficiency, and I do recommend it. Pentoxifylline, it's a vasodilator.
Is there any relationship to neuropathy in veins?
There can be, actually. Yeah, so if you have significant venous insufficiency, you have a lot of swelling in your legs, over time that can cause damage. It's not fully understood, but that can cause issues with the nerves down there. If we do these treatments, it doesn't always completely reverse the neuropathy. Some of that damage is already done, but it is somewhat related. She asked about high cholesterol. Not necessarily for the venous system. The arterial system, definitely. So if you have, we're not really talking about the arterial system today, but if you have evidence of artery disease, then yeah, cholesterol usually plays a role in that.
Is discoloration of the skin reversible?
Not if it's significant and severe. So if you have significant discoloration, like in the ankles where you have that darkening of the skin, sometimes that isn't reversible. It can improve over time with those conservative measures in addition to treatment, but some of it doesn't always completely reverse, but it can get better.
At what stage, when you first notice like a spider vein, would you recommend consultation with the physician?
So for a spider vein, if it's small and it's not bothering you from a cosmetic standpoint, you don't necessarily need to go and see a physician about that. It's not something that's life-threatening to you. It's not going to cause any issues for you, unless it's bothering you from a cosmetic standpoint, or if you start having pain in that area, redness, irritation, then I would recommend seeing a physician. But if you just start having little spider veins and they're not bothering you, they're not threatening your leg or your life in any way, so you can kind of just manage that conservatively with compression therapy.
Compression stockings come in different lengths. Is one better than the other?
That's a great question. So it depends on where your problem is. If you notice that you have bad varicose veins up in the thigh region, we typically do recommend that you wear compression all the way up to the thigh if you can tolerate it. Now that can be difficult to tolerate, especially if you're working and you're getting hot and things like that. So really, we recommend it, but if you can't do that, I would want you at least to have something up to the knee. They also come in different gradings. So 15 to 20 is the lower one, 20 to 30 is typically the one that I recommend for patients who come in with venous disease, signs of venous insufficiency. So if you're looking on, Amazon, whatever, 20 to 30 is what I would recommend. Okay?
Hello. So spider veins and varicose veins runs in our family history. And my mom was telling me when she went through menopause, she got more veins. And how is that related, menopause and varicose veins or spider veins?
It all has to do with the changes in your hormone level. As far as the real underlying reason, it's not fully understood. But changes in your hormones with pregnancy, changes in your hormones with menopause can make your venous insufficiency worse.
For a patient that has bad circulation,
Mm-hmm.
and has the issue with varicose veins along with heart disease, do you recommend for them to do it? Would it improve their heart condition, or?
It won't really improve their heart condition. It could help with swelling. So patients who have heart problems, heart failure, tend to have a lot of swelling in their legs regardless. And then on top of that, if you have a level of venous insufficiency, if we treat the venous insufficiency, that should help with the swelling. It won't really do much for the heart failure, unfortunately. It's not really related.
Improve the blood flow.
Oh, the blood flow to the heart? Not necessarily. No. It's a good question, though. So I'm over here just in this room next door. I'm doing vein screening. I have a booth there with my staff. If you have questions that you didn't get to ask in this room, or if you just didn't want to ask in front of everyone, I'm happy to answer questions. over there and just come and see me. I'll take a look at your legs.
Thank you so much. Oh my goodness, what a wonderful day we've had here, and we have learned so much. Thank you again, Dr. Jokic. And with that, I'd like to thank everyone for joining us today. We hope you found, again, these discussions insightful and had a bit of fun while you were here. I'd like to recognize also very much the lovely Advent Health team members for hosting the educational booths and sharing important resources, as well as our community vendors in our marketplace. And then last but not least, let's give a big round of applause for all our amazing females, women health specialists for joining us today. Thank you again to our wonderful marketing team that put this together. Thank you.